Good morning and welcome to this session of the Committee on Health and Human Services. This morning's session will be to give Dr. Shaw a chance to ask some questions that have been asked by the committee members and submitted to the department. And Dr. Shaw, is it okay if we take the questions section by section so that you address the major topics of priority, access, and long-term outlook, and ask questions after each section?
By all means, Mr. Chairman, I am your guest and at your disposal.
Well, thank you for being here, and I understand you need to stop at 12. We'll make sure everybody in the committee has a chance to ask questions, and then after you have to leave, we'll stay as long as we need to finish collecting questions around the horseshoe that we can then give to Molly for answering later. So we'll do it that way. So let's quickly go ahead and introduce ourselves, starting with Representative Griffin.
Good morning. My name is Abigail Griffin, and I represent House District 102, which is Glenburn, Levant, and Condescake.
Representative Connor.
Good morning. My name is Representative John Connor. I represent House District 58, which is part of Lewiston.
Representative Madigan.
Good morning. I'm Representative Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Zager.
Hello, Mr. Chair and everyone. Thank you so much. I'm Sam Zager. I represent District 41 in Portland. And I'm going to apologize in advance that I'll be ducking out to testify before state and local government in a little bit. I look forward to Dr. Shaw's testimony. Thank you.
Thank you. Representative Lemlin.
Good morning. I'm Michael Lemlin, House District 88, which is Chelsea, Jefferson, Whitefield, and half of Nobleboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the 6 coastal towns, Boothbay Harbor, South Port Edgecombe, West Port Island, and part of South Bristol. Thank you.
And Senator Baldacci is state and local. Representative Perry hasn't joined us, nor has Representative Javner. Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative and Chair Meyer.
Good morning. I am Representative Michelle Myers, serving Southern Maine's House District 2, which is Elliott and parts of South Berwick and Kittering.
And I'm Ned Claxton. I represent Senate District 20, which is Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. And as I said at the start, we also want to introduce our analysts. Anna.
Hi, I'm Anna Broom, and I am a nonpartisan employee in the Office of Policy and Legal Analysis.
And I saw Erin there. Yes, Erin.
Good morning. My name is Erin Dooling. I'm also a nonpartisan employee in OPLA.
And Carrie Withy.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
The latter 3 people are the glue that keep the committee together. So thank you for being here and thank you for your help. So as I said at the start, we'll invite Dr. Shaw to answer the questions that were submitted earlier and stop after each relative section so we can hear some questions. Dr. Shaw, the chair is yours.
Very good, very good. Well, Senator Claxton, Representative Meyer, members of the Committee on Health and Human Services, thank you for the opportunity, invitation to join you to discuss where we are and where we hope to be going with respect to COVID-19 vaccinations across the state. Senator Claxton, as you noted, I will tick through these section by section and halt after each section to take any questions, comments, additional feedback, if that works for you, sir.
Thank you.
Okay, very good. Well, without further ado, I know there are more questions than today's time allows for, so I will go ahead and jump right in, and I will be starting section by section, answering them in the way that in the order that Molly had sent them over to me. And the first question that we lead off with is whether from an epidemiological standpoint, vaccination of incarcerated and detained individuals is an efficient public health strategy and should be prioritized, or in the alternative, at what point, once we have adequate supply, might such individuals who live in crowded conditions, facilitated in areas that are poorly ventilated, when may they be expected to be offered the vaccine? And if the incarcerated individual meets the criteria as it pertains to age or health status, will they be offered the vaccine? And I very much appreciate that question. That's something that has been on our minds as we have been thinking about and planning for vaccine and vaccinations. Let me start at the top by noting that a recurring theme that you will hear me discuss and refer to is at this point is a significant supply constraint facing the United States and the state of Maine regarding the number of vaccines that are coming into the state every week. To put that in perspective, although there have been some increases in the last 2 to 3 weeks in our weekly allocation, right now, each week in Maine, we are receiving approximately 20,000 new first doses of vaccine for distribution across the state. When you consider that against our population of 1.3 million, 1.4 million, getting only 20,000 new doses per week means that we are continuing to face a significant supply side constraint. We, of course, hope that that constraint will improve over the coming weeks and months as production increases and additional vaccines may be authorized by the US FDA. But right now, the baseline situation that we face every week is how to allocate what remains an incredibly precious resource. When it comes to individuals who are in carceral settings, that question comes to mind, as it does with any individual in a congregate setting. We would absolutely like to prioritize those who are in congregate settings right now, as well as those who are living in shared living conditions or who have chronic medical conditions, as well as those who suffer access and other types of inequities. Right now, again, however, in the face of what amounts to extremely resource-constrained allocations, we have chosen to focus, in order to protect individuals in carceral settings, we have chosen to focus on vaccinating the entry point to how the virus is often introduced, which is to say by vaccinating staff within carceral settings, be they state prisons or in jails. In most of the outbreaks that Maine CDC has worked on in any kind of congregate setting, as well as the literature surrounding outbreaks in incarcerated settings nationwide, a recurring theme that comes forth is that those outbreaks are often introduced by staff members, be they corrections officers or others. By vaccinating those frontline corrections officers and other staff members, we can afford a high degree of protection to other inmates within the facility. That strategy in Maine, at least initially, seems to be bearing fruit. Throughout the entire, and we began this process of vaccinating those individuals several weeks ago, and we believe that it's already starting to show some degree of benefit. Throughout the entire Maine Department of Corrections facilities across the state, throughout the entire month of January, there was one recorded case of COVID-19 among an inmate. So we believe that the strategy of providing vaccination for frontline staff is a barrier against the possibility of introducing it into the wider population. Most definitely, when vaccine becomes more available, whenever that is, we hope to be able to offer vaccine not just to those in carceral settings, but to those across different types of congregate living settings across the spectrum. When that is very difficult to predict. Right now, we are still seeing only small increases in our week-on-week allocation. The next question is, given it's in connection with our strategy, which the question says, the current vaccination strategy states, given the limited number of vaccines, people age 70 and older will be vaccinated first in phase 1B. Maine will then move to residents 65 to 69. The question is, what about giving priorities to those 70 and older who possess various underlying medical conditions that are listed on the CDC's webpage? The questioner notes that the existing scheduling system is not set up to ask these necessary qualifying questions. So let me first start by talking about the system that we've put into place right now. The data show that people age 70 and older constitute more than 85% of the COVID-19 associated deaths in Maine to date. One of the considerations we have as we are trying to vaccinate, not just with velocity, but also with equity, is making sure that we don't create a system that requires so many levels of understanding to be able to implement. Indeed, just this morning, I was on the phone with members of the healthcare community in and around the Bangor area to discuss, among other things, the launch of a large-scale community-facing vaccination site at the Cross Insurance Center. And one of the physicians associated with that site indicated that what has been very helpful to them in ensuring high throughput is having very clearly delineated bright line rules, age 70 and over, as opposed to having to try to check off different boxes that denote certain health conditions. There's a bit of a trade-off between prioritizing even more by risk within the 70 and over category versus creating a system that is easily implemented. That's why for right now, for this stage of the vaccination process, we are just focused on all those 70 and over. Is the system perfect? No. There may be individuals who are 70 and 71 who are in great health that are vaccinated, and individuals 74, 75 who have significant medical problems who have not yet been vaccinated. That is an unfortunate trade-off, but at the same time, one of the ways that we can protect everybody as quickly as possible is to encourage systems and put systems in place that get to the highest throughput possible as quickly as possible. And that's why we've gone the route that we've had. The next question is with respect to critical frontline workers. And the question reads as follows. The vaccination strategy states, quote, in phase 1B, critical frontline workers are to be determined. The US CDC's advisory committee has recommended the following critical workers be considered frontline: food and agriculture, postal service, manufacturing, the list goes on. We further say in our guide, the state of Maine will review this list and make determinations as this phase approaches. Has the determination been made, and when can they expect to begin receiving the vaccines? And the answer is, at this time, no finality has been achieved with respect to when frontline critical infrastructure workers may start being vaccinated. I say that because as we stand right now with our current input of vaccines that are coming into the state, even with the projected increases in weekly allotments to the state of Maine, we will not have received enough doses by the end of this month to vaccinate even half the state's population, 70 and older. We still have a lot of work to do to just make our way through the group that are 70 and older. For reference, that group comprises 193,000 individuals. More than 10% of the state's population is comprised of those who are just 70 and older. And again, at this time, we are only receiving vaccine for about 20,000 such individuals every week. That doesn't even account for public safety workers, still some healthcare providers who are awaiting vaccination, as well as residents of long-term care facilities of any age. So given our current vaccine inputs that are coming into the state of Maine, it may be some time before critical front-facing workers may be vaccinated. I don't know when that time will be. It really does depend on how much more vaccine we anticipate seeing in the state. Again, right now, the speed with which we vaccinate is governed almost entirely by the supply. Once that supply expands, we very much look forward to these critical frontline workers being considered for vaccination as that supply increases. So that's the first section, Senator Claxton and Representative Meyer. I will pause and take any follow-up or additional questions.
Thank you. Before we get to some follow-up questions, I know we've been joined by Representative Javner. Would you like to introduce yourself?
Yes, good morning. I'm Representative Kathy Javner. I represent House District 141, which is located in Penobscot and Washington counties. And I apologize for being late.
Representative Craven has joined us too.
Thank you, Mr. Chair. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston. And I was struggling with my link. That's why I'm late. Sorry.
We'll count that as an excused absence. Representative Perry.
Good morning. I had the same struggle with link. I'm Representative Van Perry. I represent House District 140, which includes Indian Township, Baileyville, Barron, Callis, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Thank you. Are there some follow-up questions? And can you indicate by raising your hand so that I can see those so we don't go around? Representative Meyer, you got your hand up first, even though you don't have a raise hand function.
That is true. And thank you, Mr. Chair. And thank you, Dr. Shaw, for being here in front of us today. Going back to the first question, which was my question on incarcerated and detained individuals here in the state. Is it, I know that the Maine Sheriff's Association and the Department of Corrections support the vaccinating of incarcerated Mainers. And I'm wondering what has been, how many of the staff statewide have received at least the first in the series?
Representative Meyer, I don't have that exact number. I know that the Department of Corrections has it as to their staff, and they just this week, or was it, I'm sorry, last week, have started also pushing vaccine to the 15 county jails for the sheriffs there. I have a number in my head that the deputy commissioner briefed me on 3 or 4 days ago, but I don't recall it, and I don't want to provide incorrect information. I know that Deputy Commissioner Thornell, with whom I speak every single day at the Department of Corrections, I talk to him every day at 10 a.m. to check in on all matters correctional. He has that number, but I don't want to give you something incorrect, but I know he is tracking it quite assiduously. And I recall being very impressed with the progress that they've made, as well as the uptake that they've seen amongst staff within their facilities.
How many, what percentage of staff would you be comfortable seeing vaccinated?
So I apologize. Yes, here's how I think about this. The goal should be 100% vaccination in any facility, be it a long-term care facility, a hospital, or a correctional facility. We should be aiming for 100% of whatever group that we are contending with, be it corrections officers, residents, staff members, nurses. We should be aiming for 100%. Is that always possible? It's not. Work schedules, so on and so forth. And that's why we go into facilities multiple times to offer vaccination. We don't just show up twice and say,
right,
either here or you're not. We go in multiple times for that exact reason. So 100% is the goal, but achieving that is very difficult. From an epidemiological perspective, 80% is really the minimum. Below 80%, and you don't start to see the population level immunity that you really need to bring down rates of disease. So I sort of answer that in 2 ways. The floor is 80%. The ceiling, though, our target is 100%.
And the absolute number is something that we can get from Ms. Bogart pretty readily, I suspect, for follow-up to the committee. Yes, Representative Connor, you had a question, follow-up?
Yes, thank you, Mr. Chair, and thank you, Dr. Shaw. Really quickly, you spoke about the 1.3 million population and how I like the catchphrase of velocity equity. I would like to add accuracy to that. I think that would be a good term. But my question really is, does the CDC have a percentage of the state that, for whatever reason, those that have either contracted the virus and have fought it off, those that have tested positive that have positive for the antibodies, or those that opt out for personal or health reasons, does the state have a percentage of the population that we can expect won't or may fall into one of those 3 categories?
Well, it's a great question, Representative Connor. And based on the data that we've seen around the vaccines and the strength of the immune response they generate, the current recommendation from the US CDC and the National Institute for Allergy and Infectious Disease, Dr. Fauci's organization, is that even individuals who have previously had confirmed COVID-19 disease should still be vaccinated. And that's because the 2 doses of the vaccine actually produce a stronger immune response than merely having just gotten infected naturally with COVID. And so as a result of that, Representative Connor, our assumption in our planning models is that everyone in Maine, all 1,344,212 people, that's the number we're using, we're aiming for or looking to set up a system that will vaccinate all of those individuals twice, given that right now the vaccines require 2 doses. If future vaccines only require 1 dose, which there's one on the horizon that may, then that speeds us up even more. But our planning assumption is that everybody in Maine be offered that vaccine twice.
Thank you, sir. Thank you, Mr. Chairman. That's all.
Representative Colleen Madigan.
Thank you, Senator Claxton. Thank you, Dr. Shaw, for being here today. I represent Waterville, and Maine General had their first kind of call-in for folks 70 and older to schedule vaccination. Many people I know, many of my constituents could not get through on the line, including my own mother, actually. But I'm wondering kind of if there's any plan to make that sign up easier for people who are in that 70 and above category.
Yeah, no doubt about it, Representative Madigan. And I'll say the eternal optimist in me recognizes that even though it's incredibly frustrating to not be able to get through, there's also some sign of encouragement there that there is such a high demand for vaccine. I say that because recall even 6 months ago, the big question in the air was, if we make a vaccine, will anybody take it? And so the fact that there are so many individuals who are lining up and wanting to raise their hand to say, I want that vaccine, I want to stay safe, I want to hug my grandkids again. A small part of me, the eternal optimist in me, says, that's a sign, that's a positive sign. Now we've got to get them vaccine. There's no question in Maine as well as nationwide, there have been challenges in getting folks scheduled. There are reasons for that. I won't dwell on those. I don't want to sound as if I don't want to make excuses. There are reasons why that's been a challenge, but the bottom line is that buck stops with me. So we are working to set up a system that will allow folks of any age to pre-register, and then if you're 70 and over, to register and get a spot more quickly. But we recognize that whipping out your smartphone or logging on to a website is not something that's easy to do for a lot of folks, particularly those 70 and over. So we're taking deliberate steps to, in parallel, have a call center available. A call center that offers that sign-up service in multiple languages, that's easy to access, that won't really be something that you have to have a computer. Really all we hope you'll need is a pen and paper to write down your confirmation number and the date and time. Doing those processes in parallel, if I only wanted to set up a website or I only wanted to set up a call center, that's a little bit easier. To do both at the same time in parallel requires a little bit of gymnastics to make sure the two are in harmony. We are not moving at the rate that I had hoped us to. That's on me. I have indicated to my team that there is probably no higher priority right now at the Maine CDC to get both of these processes moving, the contract with the vendor for the IT piece, as well as the contract with the call center, so folks are available. Are we moving at the speed that I wanted to? No, we're not. That's on me, but we're working as hard as we can at it.
Thank you.
Senator Moore.
Thank you, Chairman Claxton and Dr. Shaw. Thank you for being here. I have an additional question that came from one of my fellow senators. And what she was saying is that she's been reading some articles where the CDC has stated that the vaccine itself does not really prevent transmission, but only lessens the symptoms. And I wasn't aware of that myself. And so her question is, why would we prioritize anyone but the elderly who, when they do have the symptoms, are so severely affected by them?
Senator Moore, that's a great question. And it's one that it's been on my mind, and it's something I've discussed with my counterparts as well as experts in vaccine epidemiology to make sure that my understanding of this issue was grounded in the latest facts. Permit me, if I could, Senator, to be just a little bit philosophical for a second, which is the answer to your question hinges on what does it mean to know something? Here's what I mean by that. Based on everything we know about vaccines for this category of viruses, based on everything we know about all of the vaccines for viruses of this sort, the COVID-19 vaccine will almost certainly reduce the likelihood of someone being able to transmit the virus without any symptoms. That is to say, stop the spread of the virus, in addition to keeping people out of the hospital. Indeed, just this morning, there was a publication that was emailed to me that I haven't read yet, but it was a paper. I scanned the abstract and it indicated that the AstraZeneca vaccine does in fact do that, which is consistent with everything we know about vaccines and infectious diseases. But another way that we sometimes say to know something in science is until there is a randomized double-blinded clinical trial with 50,000 people in it that's published in the New England Journal of Medicine, I'm going to say I don't know the answer. And that's when you hear people say they don't know, they're really saying they're being scientifically cautious, because has the full paper been vetted and published in the New England Journal of Medicine yet? Not yet. But based on everything we know about vaccines and infectious diseases, this vaccine will not just keep people out of the hospital, not just keep people alive, but it will also reduce the likelihood that they'll spread it. Will it eliminate that? Probably not. No vaccine does that. But it will reduce significantly the likelihood of that transmission without symptoms.
Dr. Shaw, it looks like before you go to the next session, you've probably already addressed question number 6, but I invite you to go ahead about access and locations.
Sure, I will dive right in. Indeed, we discussed the scheduling issue. That was a question that was here. And the bottom line there is we are working very intensely to try to bring on these parallel systems for folks for whom broadband or smartphone access is something that's available to them. They will be either able to pre-register if they're in a later phase, or register if they're in a current phase. And then again, working to bring on a call center to do that in partnership with the online piece. It's important to note that at this time, every single vaccine dose that comes into the state of Maine is used in relatively short order. So we are not in a situation where there are tens of thousands of doses that are awaiting an arm. Doses come into the state, and thanks to the great work of healthcare providers across the state of Maine, we are able to get them into arms ASAP. All of this is being done in anticipation of there being even more doses being made available to the state. The next question is, what should PNMIs in similar settings, as well as home care workers who are non-medical but going in and out of homes, expect? The answer there is a bit more challenging. Right now, we have focused our prioritization within phase 1A to those who work in a distinct healthcare capacity. Now, this does include home care workers, nurses who are going in to provide therapy, or physical therapists who are going into homes. Those are included as part of phase 1A. And groups like Androscoggin Home Health, among others, have received vaccine and have seen great uptake amongst their staff. But the non-medical workers who are noted here, that may be a little bit longer, a little bit further into the future. We recognize that they do pose a risk, so we are aware that they need to be vaccinated. But right now, the focus has been on those who have who are medical, so we could get them vaccinated as quickly as possible. For the others, it still may be some time. Similarly, the next question on the list is an interesting one. It's a comment or question that was sent in from a constituent. This vaccination rollout is for the birds, and there's other concerns that are raised. It's difficult to get through. The only response I get is that the vaccines have run out. This is worse than Russia. I'm not sure I agree with that sentiment. If you take a look at any of the various trackers, whether it's the US CDC or the New York Times or Bloomberg, that look at how well states are doing in terms of getting shots into arms, as well as using their allocated supply, no matter which of those you look at, Maine is consistently in the very, very top tier amongst all of the states. Our vaccination rates are, as of yesterday, just among the highest in New England. I think we were on par with Connecticut and slightly ahead of Vermont. And then relative to the rest of the country, we were at the very top of the league tables, up there with West Virginia, Alaska, some of the other states that have successfully stood up systems to get vaccine into arms as soon as the doses come into our state. That doesn't negate the fact that I know that there's widespread frustration. Much of that frustration is because there's simply not enough vaccine to go around. And we recognize that scheduling is difficult as well. No question about those things. But I don't believe that our system is the atrocity that the constituent notes it to be. Is it a challenge? There's no question about that. But we hope that it will get better as the supply increases. And then finally, what are we doing? The question is about Washington County, but more generally, what are we doing about rural areas of the state where there tends to be an older than average population? And let me just note with specificity to Washington County, ever since our very earliest weeks of allocation, we have made sure that hospitals in Washington County were receiving doses of vaccine. Both hospitals, indeed, Calais Regional Hospital and Down East Community Hospital, both of which have done great jobs increasing their ability to conduct high throughput vaccination. And I can go back and check, and we make all of these allocations public. They're on our website, but we have consistently made sure that rural parts of the state have received vaccine, Washington County included. This week, on top of allocations to hospitals, we also started allocating vaccine to FQHCs in Washington County. So this week, vaccination sites at FQHCs in Lubec and Eastport also received at least 100 doses each to vaccinate members of their communities. The same pattern we've seen, we've taken deliberate steps to make sure that, for example, Aroostook County is covered. And indeed, healthcare providers in Aroostook County were ready to go the day vaccines started arriving. They had people lined up the same day doses started arriving. And as a result of that, or as a result of that planning, as well as deliberate actions to make sure that no part of the state was disproportionately left behind, Aroostook County right now is seeing the highest vaccination rates across the state of Maine. And then the last question is, do hospitals bill for vaccine administration? There is reimbursement available for the administration of the vaccine. Hospitals do not and cannot bill for the vaccine itself. So Senator, that is the access and locations section.
Yes.
I will turn it back over to you, sir.
Thank you. Again, I'd ask people to put their hand up if they have a question. Yes, Senator Representative Craven.
Thank you, Mr. Chair. Thank you, Dr. Shaw, for all of the work that you've been doing and the CDC's been doing in this really, really difficult time. I know it's so stressful, but I just wanted to say that we are really pleased here with the with the rollout in Lewiston from our two healthcare providers, and also the FQHC got doses from St. Mary's as well. And so it's not all, I just wanted to put some positive spin out there, because some providers are doing a great job and they're making it easy to enroll online. I don't know how the phone registrations are going, but just wanted to let you know that, and that some places are doing a great job. Thanks.
Representative Craver, I appreciate the positive feedback, and it means a lot to me, and I'll pass it on to our team. I'd be remiss if I didn't mention or expand upon the FQHC that you noted. Starting this week, and for weeks now, we have been working with St. Mary's and the B Street Clinic to offer vaccines and vaccinations to the community that they serve. And at some point in the near future, the date escapes me, so I don't want to be incorrect on that, but at some point in the near future, our colleagues at the B Street Clinic are going to be offering a special vaccination clinic for members of the New Mainer community who are 70 and older. So a clinic tailored to the concerns and the needs that they've got, and using that deliberate vaccine allocation that we provided.
In yesterday's TV segment, you used the term collectives. Is that what got the folks in Aroostook County so well advanced that they had a collective and they were ready to go on day one? And who owns the responsibility for putting those collectives together? Because I also heard you say yesterday that it didn't sound like there'd been much success yet in York County, except for some efforts at the hospital in Stanford.
Correct as to most of that, or all of that, and I'll expand upon it, Senator. Yes, in Aroostook County, I've been really just thoroughly impressed with the way that the leadership of the hospitals from Holton all the way to Fort Kent have come together, as well as the independent pharmacy in the area, Hubert's Independent Pharmacy. That consortium of individuals has come together to share doses as well as to focus on high and at-risk members of the community, long-term care facilities, and others. We are still separately allocating doses to the hospitals, but they have an understanding that doses can and should be shared. More recently, just about 2 days ago, Chris Judy from Cary Medical Center, the CEO, sent me a letter outlining a plan that they have for Consortium 2.0, which is to say they are working to secure or utilize an ultra cold storage freezer so that they can start receiving the Pfizer vaccine and use that in a more thoughtful, almost hub and spoke approach. I'm very impressed with the way that they have approached this. And indeed, the proof is in the pudding. Again, the per capita vaccination rates in Aroostook County are, I think, the highest in the state. All of this information is on the new dashboard that we have just stood up. I will find the link to it in just a second here, or Molly, if you have it at the ready. But I would really urge or ask everyone to take a look at that dashboard. It has just a ton of data, specifically around county level vaccinations. York County we've been working with York County a bit more deliberately in recent weeks. The county being a bit more geographically spread out, we've sort of taken different approaches, working with York Hospital, Southern Maine Healthcare, as well as a new site in the northern portion there at Scarborough Downs that's going live today. The thing in York County is just there's a much higher population. I believe their population accounts for 16% of the state's population. So we are making sure that there is that high throughput vaccination available, one in Sanford, one associated with York Hospital, Southern Maine Healthcare, and then again in Scarborough, but complemented by smaller vaccination sites because those large sites may not be for everyone.
The other comment I wanted to make was that you listed as the primary issue related to expectations these days was the number of vaccines available. I also would include communication as one of the sources. And I'm hoping that, and I don't need an answer to this, but I'm hoping that the department is looking at how that you're now 70 and qualify got misunderstood as they're knocking on your door ready to give you your vaccine by a lot of people. So I think that created a gap in expectations that has fueled at least some of the frustration. And I'm hoping the department is looking for opportunities to do that communication piece better. Representative Meyer?
Yes, thank you, Mr. Chair. Building off a bit of what Senator Claxton just noted about communication, I wonder if CDC has got a dialogue or a collaboration going with the AAAs with regard to utilizing them statewide to help our seniors navigate the system.
The answer is yes. I've worked with, and our team has worked very closely with Director Saucier at ODES to take advantage of the work and the opportunities that the AAAs have, the connections that they have with older Mainers in their community, everything from letting them know how and when to access vaccines and vaccinations, assisting with this somewhat Byzantine registration process that we've all heard about, as well as more granular things like transportation, if that's available to them. The AAAs vary and differ across the state in terms of their own capacity. So we're working with them on terms that make the most sense for the AAAs.
And because information differs regionally, is there communication with each separate AAA so that, I guess my question really is, can I begin to suggest to some of the many seniors who are reaching out to me here in York County, where we've had some issues, can I begin to direct them to the AAAs for information?
I don't know the answer to that. I know that there have been conversations with the Southern Maine area, the Southern Maine AAA. I don't know if they are ready for that degree of activation, Representative Meyer. The worst thing I can do right here, right now, is to say yes and have that be incorrect. We will find out the answer directly from Director Saucier and let you know what the status of their activation and their readiness is.
Thank you, Doctor.
Senator Moore.
Thank you, Senator Claxton. Just another little question about the the system that you're working on or you're having them work on. Will we be able to actually have like a standby list? So if somebody pre-registers, they fall into that category, and that there would be a standby list so that it would automatically populate where they're not having to keep calling in at noon on Tuesdays or whatever it might be there. And then along with that, will that create a database possibly for a potential mobile effort where we'd actually go out to an area, especially in the rural sections of Washington County, for example?
So as to the former question, yes, the concept of operations is not just registration, but also pre-registration as well. So folks raising their hands saying, let me know when the slot is available and I am ready to go. So we want to make sure that we can do both. Indeed, pre-registration is actually the principal goal. We want folks to know that they've got a place in line. Pre-registration has started rolling out in some other states, 3 or 4 that I'm aware of. It is fraught. There is a risk in doing it because when you open up pre-registration, a lot of folks pre-register, and it may not be for weeks, months before there is enough vaccine to give them even a date on the calendar, let alone when that date comes. So there is a risk with pre-registration, but it's a risk that I think we should take because at least lets people know that they are in the line and that they will be notified when a spot is available. With respect to mobile vaccination, it is something that we have looked into and are working with at least one provider group to explore. The experience with mobile vaccination in some other states has not been uniformly positive. The daily throughput is very low, on the order of 15 or 20 a day. And so it's something we have to balance off. In very rural parts of the state where there is no other way to get access to vaccine, it may be the only opportunity, but we have to balance that off against the possibility of folks coming to a site that can achieve higher throughput versus waiting longer until the mobile unit can be scheduled to get out to them, which could take many, many days, if not weeks. As with so many things in COVID, particularly vaccines, it's a trade-off between those two.
And just to follow up on the mass vaccination site, it would help me to know what the criteria are or generally what you're looking for to have something be considered a mass vaccination site. Locally, we have people giving immunizations on Saturdays at some of our mass vaccination sites with a very limited number of doses. So that's, to me, doesn't meet the criteria. I have a friend in York who has a small practice and wants to know when he's going to get his. That doesn't meet it. But I also have a FQHC in the Leeds area who could do 600 people tomorrow if they got vaccine and they already have the freezer. So it would help to know what these collectives should be working towards. I'm sure that's defined somewhere, but if Molly could get that, I'd be glad to share that with whoever asked me.
It is on our website. And what we are looking for are a few things. When I think of a large scale community facing vaccination site, I'm thinking of a place that meets, among many criteria, the following things. The ability to do on the order of around 1,000 a day, if not more. The ability to be agnostic as to who is being vaccinated. I don't care if you're a patient here or not. If you've got a shoulder, we've got a vaccine. The ability to have ample parking, the ability to have ample spacing, and the ability to have a system in place so that not a single dose is wasted. When you apply those criteria, the space criteria, the observation criteria, the need to have parking, all of those things, it turns out there's not a lot of spots that really check off all of those boxes. And that's why we've zeroed in on the places that we know really do. The Cross Insurance Center, places like that, can do all of those things in spades. That is not to suggest, Senator, that independent medical practices will never receive vaccine. That is not my position at all. But in an era of extremely limited supply, we have a question. If we get 2,000 new doses next week, we're not. But if we were to get 2,000 new doses next week, what is the best way to deploy those? Is it over a 2 or 3 week period, or is it in one day? And the sooner that we can get all of those shots into arms we are in a situation where new variants are literally at our doorstep. The new variants have been described south of us in Massachusetts and down north of us in New Brunswick. It is almost a certainty that if they are not here, they will be soon. Every day matters. And 1,000 a day or 2,000 a day, as opposed to 2,000 over 14 days, in epidemiological terms, makes a big difference.
Thank you. Thank you. Want to go on to the next section?
Yes. Okay, next is the long-term outlook. And the first question is, give us a chart of what happens, or sorry, what numbers of people we need to vaccinate to reach herd immunity in Maine, and when that is likely to happen in the state of Maine based on the current projections of vaccine supply. So let's go through the numbers first. Again, based on our latest census population of 1,344,212 people, the general mathematical models suggest that in the area or in the range of approximately 80% of people need to be fully vaccinated in order to achieve that population level immunity. Could it be 75 perhaps? Could it be 83 perhaps? But most of the papers and the experts in vaccine epidemiology with whom I've consulted have zeroed in on roughly 80%. Translating that number, that means about 1,075,000 people in Maine would need to be vaccinated in order to achieve that number. If you think about that, what that really means is that right now, based on the current 2-dose series, that really means that we have to be doing on the order of 2 million shots in arms in order to achieve that. Again, we can adjust that if there is a 1-dose vaccine that is authorized. But right now, our concept of operations is that we need to deliver 2 million shots in arms with the current vaccines we've got. The rate at which we achieve that 80% or so threshold right now, as a result, is entirely driven by the supply of vaccine. There are different projections that the US CDC and the vaccine manufacturers have put forth about what the supply chain or the supply pipeline looks like. They seem to be revised both upward and downward every week. So I haven't put much stock into those. What I've relied upon is what the White House has indicated. And what they've indicated is some degree of stability for the next 3 weeks. Think about that. We're getting 20,000 doses a week. And for the next 3 weeks, we're probably going to get about the same. If we're looking at doing 2 million shots or 1 million people, and we're still talking 25,000 a week, it could be a while. That is why production needs to increase and more vaccines will hopefully be authorized. If both of those things happen, my hope is that if we can get to a point at which we are doing roughly 90 to 100,000 shots a week, thereabouts, we can start making significant inroads toward getting to that population level immunity. But in order to do 90 to 100,000 shots a week, we've got to be getting 90 to 100,000 shots a week. And right now we are many-fold difference away from that. The last thing I'll mention around this is I've gotten a lot of questions around why I am so laser focused on these large scale or public-facing community vaccination sites, both from my own staff as well as healthcare providers and members of the media. Why is the only thing Shaw talk about are these mass vaccination sites? And the reason is as follows. If we maximized every available channel for vaccination in the state of Maine, every FQHC, every hospital, every pharmacy was doing what they say their maximum throughput would be every single day, every single week, we still wouldn't be at a place to get us to that 80% for quite some time. The only way that we get to that 80% mark in any reasonable amount of time is by having these large-scale mass vaccination sites make up for that delta. The delta differs based on how much vaccine we're getting, and I've got models that look at all of that in different ways. But the reason I am so focused on that is because relying on our existing channels, it will take us way too long to get to that 80 or 80% or so threshold. The only way we make up that difference, the only way we pick up steam is through large-scale vaccination. And then finally, the last question, or the next question, is while the improved public health metrics, including a decreasing positivity rate, are encouraging, the recent guidance on indoor establishments as well as the resumption of extended evening hours, makes it seem the word used as dissonance. How do we explain to our constituents, many of whom are high risk due to comorbidities and age and still waiting for vaccines, that we are loosening restrictions on activities that could increase community transmission and result in a spring surge? That's a great question. And it does seem discordant. Why would we be letting off the gas at a time when we are concerned? And the answer is a couple of fold. The first is that one of the reasons we instituted, for example, the 9 p.m. closure was a significant concern around Thanksgiving, folks coming back home, college kids in particular, but everyone congregating, going out to bars late at night. The same thing carried through over the December holidays as well. Having moved beyond the holiday season, we think that there is some degree of safety that can be achieved by allowing a later closing time. We haven't relaxed any of the other restrictions around indoor gathering limits, travel into the state, masking, any of the other core public health that we know to be very, very effective. The only thing we've really changed is allow restaurants to serve a little bit later into the evening. We think that's an acceptable trade-off, given that, again, we know that everything we do has benefits and risks associated with it. In this situation, we felt that the risk, to the extent that there is one, was an acceptable one. It also recognizes that a lot of folks who work in the restaurant industry are themselves struggling, and allowing them a couple of extra hours of business, although it does pose a small risk, also has benefits in terms of their ability to earn a wage.
Dr. Shaw, before you go on to the next section, I want to make sure that everybody who hasn't had a chance to ask a question gets maybe the opportunity. So we haven't heard from 4 or 5 people, but if you have a question and want to put your hand up, we'll try and squeeze it in here. Otherwise, we'll go on and answer the last several questions. I don't see any hands popping up, so.
Okay, good. The last couple of questions are relatively, forgive the succinct answers, but they're pretty straightforward. So I will be more directed here. So adverse reactions beyond VAERS. Are we utilizing a system to track vaccine injuries specific to the COVID vaccine? What we are doing, what the US CDC recommends, is that all state health departments, as well as medical providers, use one single system to avoid duplicate or underreporting. So Maine CDC, as well as the other 49 state health departments, are all using the VAERS system. We found that it works very well. When providers in Maine have observed certain adverse reactions, they have reported them, and they've been able to get those investigated and get in touch with us as well as US CDC very quickly. And then the next question is, what have been reported reactions to the vaccines? What we've seen in Maine is what has been seen elsewhere across the country, which is that there have been very, very few instances of individuals who have had some degree of adverse reaction. Maybe a little bit of hives at the site of infection, maybe a little bit of swelling or sweating associated with after the vaccine or vaccination itself. We have had at least 2 individuals that I'm aware of who have required epinephrine, both of whom were individuals who were known to have pre-existing allergies. I know at least one of them carried their own epinephrine pen. I don't know about the other. And notified staff at the vaccination site. Both were in hospitals that they had pre-existing allergies. Both individuals were monitored not for 15 minutes, but for 30 minutes. When some degree of symptoms developed, they were immediately administered the epinephrine, and neither was admitted to the hospital. They were both doing fine. Indeed, one of whom I interacted with said that their only regret was that they wouldn't be able to get the second dose of the vaccine. And finally, a couple of other questions under the miscellaneous category, one of which is, how's the new administration and how is the US CDC working with us at this point? Bottom line, it's going very well. We have had increased communication with them on all levels, at my level, at my staff level, so that we have great insight into where their head is at and what they are doing. One of the things that we urged the Biden administration transition team to focus on was pre-decisional deliberation, consulting state health officials before big policy changes were made, not after. And they have done so, and the benefits have been manifold. And then the next question is, last time I said my wish list would include more vaccinators. Is that still so? What else would help? And the answer is yes, having more vaccinators would still help. we've been, since I last spoke with you, working with schools of nursing to add more vaccinators to the force here in Maine. Indeed, you may have noted last week that UMaine announced that 250 nursing students would be joining the vaccination effort. That is the type of work that we are trying to do. We're working with Husson University to do the same thing. So having vaccinators would still be very, very helpful. The other thing that we need, in addition to the everyday things, is experts on logistics. Having these large scale mass vaccination sites work and work well requires not just vaccinators, but individuals with expertise in running big operations on the ground. Someone who got their start at Southwest Airlines, checking people in, and then maybe worked at Disney for a couple of years, and then spent some time at FedEx. If you happen to know folks like that who are looking for a job in Maine, let me know, because I would love them to operate some of our sites. So, Mr. Chairman, with that, I will take any questions.
And I understand that you need to step away right at noon, Dr. Shaw. So I want to acknowledge and respect that. Are there any questions that folks would like to pose at this point? We're going to go around the horseshoe. Representative Javner.
Thank you, Chair Claxton. I appreciate that. Thank you, Dr. Shaw. I apologize. There is one more question, number 15, with the vaccines being administered to our residents of nursing homes, assisted living facilities. When will they be receiving new guidelines for family visits? That was my question.
Yes, no, I just noticed that it was on the next page of my notes. So here it is. I'm not sure what the answer is going to be there. I know that we are considering that. Much of this, Representative Javner, is governed by U.S. federal CMS and not so much state requirements. CMS has put out, they have not updated their guidance to account for the possibility of vaccines or vaccinations. Maine CDC has. We indeed earlier this week put out recommendations suggesting that if you've been fully vaccinated and you encounter somebody with COVID-19, previously you would have needed to quarantine, but if you're fully vaccinated, you don't need to do that. Now, how does that relate to, or how does that square with nursing homes? Right now, it's too early to tell. We still need a little bit more data around exactly how much the vaccine affords protection in congregate living, especially long-term care facilities, before I would feel comfortable really changing things, for example, specifically around visitation policy. I think it's coming, but when, that's the bigger question.
I don't see any hands up. So have we fixed the problem of collecting race and ethnicity data as we administer?
Well, no, we have not, but we have analyzed the problem much more deeply. And the problem is such as it is. I don't want to denigrate folks by calling it a problem. The source of the lack of data is twofold. Number one is that many individuals don't feel comfortable providing their race or ethnicity. When we've queried folks, they've said, I don't know why you need to know my race so that I can get a vaccine. Similarly, we've also had situations where providers are not asking or collecting that information, or more appropriately said, are not explaining why those information are useful to public health authorities, and what we do with that and what we don't do with that. So it seems to be on both ends. It seems to be a reluctance to share that information, not seeing a direct benefit on the part of the person offering it. And then we need to do a better job making sure providers are asking for it and urging folks to share that information with them at the site of vaccination.
If you have time for another question, Senator Moore.
I guess, thank you very much, Senator Claxton. My question would be, since all of us here on the HHS committee represent constituents throughout the state of Maine, having just 1 hour of time with you, Dr. Shaw, I guess I would ask if there would be more opportunities for us to meet with you on a regular basis to get updates like this, because it's constantly changing. It's a constantly changing world. And so I guess that would be my request on behalf of my constituents as well.
Thank you, Senator. I definitely appreciate that. Molly and I have started to work on what would make the most sense. You're right, things are changing every single day. If I'm not able to join you, we're trying to see if there are other members at Maine CDC or DHHS that can brief you on all of these changes. So it's so we hope to have something of a rotation or a speakers bureau of sorts that can make sure that the legislature is up to date on where things stand.
And in between those meetings, please don't ever hesitate to shoot me an email, send me, give me a call, send me a text, whatever works. I'm more than happy to help out with any of those.
Thank you, Molly.
We are trying, Senator, to put as much information as we can on our website. That's why I pushed very hard to get the dashboard that Molly provided a link to on the website. We're trying to put all of our guidance documents on there. That website can become a thicket. I understand that. I totally get that. But we are trying to make sure that at least the top line data around testing, where to go to get tested, once we get the pre-registration system set up, making that very prominently displayed, as well as all the daily data changes. We're trying to make that as public facing and as accessible as possible.
It was helpful to have the dosage distribution available online, because up until that point, the person from the FQHC I was talking to was so frustrated that I pointed out that the hospitals were only getting 1,000 doses for a much larger population, that she understood what the constraints really are. So thank you for putting that data up. I see no other questions, and I know you need to be doing something at 12. And I know that Molly and the analysts will be working to get you or some portion of your staff back here to make this a more regular visit. That's certainly been the intent. And we very much appreciate your taking the time and answering these questions this way. We'll collect some more and get those to Molly so you don't forget about us.
Well, Senator Claxton, Representative Meyer, members of the committee, thank you for the opportunity to join you. I appreciate the questions. I appreciate the discussion. So thank you all very much.
We're representing the concerns of our constituents as best we can. And so having this kind of information is helpful to those who are struggling right now. So thank you for that.
Thank you. Thank you, everyone. Have a good day.
So if anybody has questions they'd like to get onto Molly's to-do list, can you put your hand up? Yes, Representative Griffin.
Yeah, Molly, I have some, from what I understand, there's 3 different manufacturers of the vaccine, and I was just wondering which ones which one comes to Maine, or if all 3 of them do, and what the differences are. And the other one I have is I've had people being concerned about the fact that the vaccine hasn't been tested as long as some other vaccines have been, and just wonder if you can just address that concern. Thank you. Thank you.
Sure, and I can tell you right now the first part. Right now we're only receiving doses of the Moderna vaccine and the Pfizer vaccine, but I think the hope is as others such as the Oxford AstraZeneca come online, we'll start seeing doses of those as well.
Are there differences in the ingredients, or are they basically the same?
That'll be something I'll have to get back to you on, but
okay.
I will do that.
Okay, thank you very much.
Sure.
Thank you. Are there other questions? Sure, Representative Meyer.
Thank you, Mr. Chair. I've got a list of questions that I'll certainly email over to Molly, and just wanted to ask here about National Guard support, ongoing National Guard support at test sites, particularly here in York County. And I know she's working on that answer for us.
Administration sites, not just test sites, but both?
Test sites is what I'm asking about specifically.
Okay.
I believe that they're being diverted to the test sites. Okay. And I'm asking for any consideration for ongoing use of the National Guard at test sites.
Mm-hmm. Dr. Shaw referenced, Molly, pre-decision notification from the US CDC. That he said that the communication was going much better, and that the state health people were asking for some advance notice. I think that same could be requested by us of DHHS for the announcement, for instance, that 70 and older qualify. the phrasing of that and how that was rolled out could have been improved, and some input from the legislature might have been helpful in shaping that message and decreasing some of the frustration. So I just want to flag that. I also have questions about, are we using the impact system or HIN to help us with tracking? Because it's got to be quite a complicated system if we're going to get 1 million people vaccinated, not once, but twice, to make sure everybody's getting the follow-up. So those are systems we've invested a bunch of money and time in over the years. And I was wondering if they're being used. And then I think those are the list of my questions. Representative Craven.
Thank you, Mr. Chair. I hear lots of people saying that they have signed up at several sites. And I know that I heard Dr. Shaw say on one of his broadcasts one day that this was a very confusing thing to do and making it very cumbersome for providers. And so wondering how you could get the message out to tell people, you know, if you're registered at one site, don't register at multiple sites, because it just muddies the water. Thank you.
That sounds like the DHHS experience with getting into various section support with multiple people getting signing up for different resources, hoping that they would, on the wait list, that they would finally get recognized in one of them. So that sounds familiar. Other questions? Representative Zager, you just joined us again. You missed. Did you have any questions of Molly or Dr. Shaw that you want her to pass along?
Thanks, Senator. I do not. I was hoping that I could find the video so that I can see Dr. Shaw's testimony that I missed.
Okay. Should be out there, and we also are. There's talk about preparing a summary document, and we're also sending additional questions to Molly as they come up. Representative Connor.
Yes, thank you, Mr. Chair. My question is about the registration. Is it a national or just a state registration? Especially if people are needing, 2 vaccines. If we have an outer-stater that moves to Maine who got the initial vaccination in their home state and then they move to Maine, how is that tracked? That would be my question. Thank you, Mr. Chair.
Thank you. Yes, Senator Moore.
I just have one that was from a constituent, and I didn't. Anyway, what she was saying is wondering if there would be any thoughts about regulations that would be in place for only those residing or those residents of a community being allowed to go and get the vaccine where it's being offered.
I have a friend who drove up to Presque Isle. It's only 4 hours to get her vaccination.
I know, and that's what's happening. And in Washington County, because we don't have any sites, that's exactly what they're doing. They're trying to go to bank. They're going anywhere that they can get an appointment is what they're doing.
So that's the kind of thing that'd be good to get regular follow-up on, Molly. So how are we doing with developing sites in York and in Washington County and the places where we're arguably lagging? That kind of information, not necessarily Dr. Shaw personally, but I think somebody else could answer those kinds of questions, because somebody's got to be working with those collectives other than him, and or helping to put together those collectives.
Right. And just one other comment about the communications. I think I was a little frustrated when all of a sudden the website was posting all of the places where they could get online and make an appointment. And I've received so many calls questioning, why isn't Washington County on there? And I didn't even know it was had been put on the website. Yeah. So that's one of those examples that we need to know, especially as the HHS committee members.
And ideally in advance, so we can. So I called a couple of the places that were listed, and the answer I got was, don't call us. So that's arguably worse. Were there other questions? Representative Zager, you had a hand up?
Well, I was just going to offer regarding there were a couple of questions about the impact. It seems to me like even in the best of times that number one, that's not crossing state lines. Unfortunately, that would be one of the benefits of a national healthcare system. But there's that does not occur even for non-COVID vaccinations. The other thing is that in the vaccination sites that I've seen, all the effort is in keeping the tempo up, and staffing is so short, in short supply, that I have not seen any populating of the impact
Okay.
registry.
And have we adequately tapped Molly, Maine Responds? Do we feel like we've gotten in touch with those people who wanted to be contact tracers or are willing to do immunizations, those kinds of things, as a resource to meet some of the needs that Dr. Shaw talked about? I don't see any other questions. That being the case, I'll entertain a motion to adjourn until 1. Well, we'll reconvene and we'll be hearing from some folks with about statutory bodies. And later on, we'll have a work session on 2 amendments that have surfaced in support of the IDD and the behavioral health communities and the rate scale. So I'll entertain a motion.
So moved.
Seconded.
Thank you all. All those in favor?
Aye.
Okay, enjoy your lunch. We'll be back at 1. Thank you. Good afternoon, everyone. If everybody who's got a picture up is really with us, then we have a quorum. Thank you. 6, 7, 8. I count 8. I can see Michelle's head bobbing as she's counting the Hollywood squares. All right, folks. So where's Carrie? Carrie, is she here?
She's here.
Yes, she is. So we can start. Are we still recording? Okay. So welcome back, everyone, to this afternoon session of the Committee on Health and Human Services. We'll be initially hearing from various folks from statutory bodies for which we have some responsibility. Afterwards, there'll be a work session. Actually, yes, there will be a work session for consideration of a couple of amendments and some updates in terms of financials. So anything that anybody wants to add at this point before we get started? Not seeing anybody with a question or concern. We'd welcome Kim Moody from Disability Rights of Maine and hear from her about her program and her responsibilities. Welcome.
Thank you. Senator Claxton, Representative Meyer, and other distinguished members of the Committee on Health and Human Services. Good afternoon, and thank you for the opportunity to briefly introduce you to Disability Rights Maine for those of you who don't know of us. My name is Kim Moody, and I'm the Executive Director. Disability Rights Maine is Maine's designated protection and advocacy agency for people with disabilities. DRM, and in every other state, was established in 1977 under the Developmental Disabilities Bill of Rights and Assistance Act. We were started back then because the conditions in institutions became public. Some of you may remember, thanks to Geraldo Rivera and a psychiatrist at Willowbrook State School on Staten Island, they kind of broke in and filmed. So Congress decided to create us. And at that time, we were expected to try to make institutions safer and cleaner and better for people with developmental disabilities. In the intervening years, though, Congress has passed legislation and created a bunch of other federal programs that have expanded the role of the P&As, Protection and Advocacy Agencies. So we now have 8 separate federal programs. Some of those programs, like DD and mental health, are specific to disability, and some are specific to issue, but cross disability, like voting access and assistive technology. So Carrie sent you our annual report, and that's a draft annual report. I say draft because we just finished putting it together last night so that I could share it with you today. It seemed like the most succinct way to show you who we are. So that lists all of our staff and all of our board and some of the programs that we worked on specifically in 2020. Inside the front cover, or for you guys right now on page 2, it shows you, or it tells you in very small font, all of the programs that we operate. And many of those are both state and federally funded. So we do mental health advocacy in the community and in state and private psychiatric hospitals and facilities. We do voting access work in cooperation with Speaking Up for Us, the Secretary of State's office, and lots of other partners to make sure that polls are accessible and voting is accessible to people in facilities and that kind of thing. In our PAIR program, which is Protection and Advocacy for Individual Rights, we do almost exclusively employment discrimination work and some physical accessibility work. We could do a lot more of that. Those are both under the Americans with Disabilities Act. This was it's a small, basically a small civil rights program that was created by Congress to serve all people who are not or who were not eligible for the 2 mother programs, the Developmental Disabilities Program and the Mental Health Program. So everyone's eligible for that program, all people with physical disabilities and so on. Luckily, when that program started, we were selected as one of the 11 pilot states. So we had time to really narrow our priorities. Some states are using it all for special education work. But anyway, We also do Social Security advocacy funded by SSA, Social Security Administration. That is about assisting people in returning to work, really. That's in Social Security's interest, obviously, to get people off the rolls and return to work. But Social Security Administration also funds us to have one full-time person who investigates representative payees. So she goes out into the community and reviews records and interviews people and makes sure that fraud or exploitation are not happening. Social Security selects those rep payees and they send us lists and tell us who to go check out. We also advocate for people with brain injury, both traumatic and other acquired brain injuries. We help people get assistive technology that they need to live independently or have greater mobility or access their public education in a more meaningful way. We do limited special education advocacy funded by you guys, really. That's limited only because of our resources. Believe it or not, still in 2021, the federal government, though they fund these protection advocacy agencies to do all this work, it's all for adults, really. There's no special education funding, but we're still working on it. I'm involved at the national level and we're still trying to get that to happen. But we do a lot of that. There's a great need for that in the state. Well, every state probably, but we also have funds to do advocacy for kids who are in residential treatment or otherwise need access to community services to keep them out of residential treatment or keep them from going out of state. We do lots of different advocacy on behalf of deaf Mainers, and that's because we took over the programs that were run by what was then the failing Maine Center on Deafness in Portland 5 years ago. We took those programs over. And then most recently and lastly, last year in 2020, Governor Mills designated us, Disability Rights Maine, as Maine's Client Assistance Program. And that is another federal program that serves clients of vocational rehabilitation and independent living, which in Maine is Alpha One, of course. That program has been around since the 70s, but it was inside state government and they contracted it out until last July. So we receive, as I mentioned, both federal and state funding to carry out all this work. We get these federal formula grants that we've been getting since 1977. And then we have state contracts that supplement the federal monies. So in addition to direct client representation, we try to create change through systemic advocacy with groups, through lots and lots of training, through policy reform, and then collaboration with all of our partners across the state. We do lots of outreach, as you will imagine. Much of that was done virtually in 2020. And the silver lining of that was we've really learned, like all of us are learning, we've really learned to find out where people are and to get access to people in the community without driving in our cars. Though we've done that, but we've also learned how to create training on Zoom and get it out to lots of places. We have a volunteer board of directors, of course, you would know that. It's required by law to be at least 51% people with disabilities or family members. We also have a mental health advisory council, which is also required by federal law that advises us on all of our mental health advocacy. I'm happy to tell you anything else you want to know about DRM and to answer any questions you may have. You've got that annual report. I think it's important for this committee to know that we exist so that you can call us whenever you want to, that you can refer clients to us, that you can let your peers know to refer constituents to us, and that we're here. There are 41 staff, I think, right now, a bunch of lawyers, a bunch of advocates, and like I said, I'm happy to answer any questions. Thank you for the time.
Thank you, Ms. Moody. So we'll get some folks to ask some questions. Can you give me some indication of roughly how many people you work with in a given year?
Yes, I can. It was lower in 2020. We had a little lull in intake calls, but we provided direct representation to 1,064 clients and another representation to another 1,859 through information referral. We have 2 full-time intake workers who are on the phone all day long, every day, talking to people with disabilities. People call in they get our receptionist, they're scheduled for an intake, and then they have 45 minutes to an hour on the phone with two very knowledgeable people who've been around here, been at DRM a long time, who can offer them something, if not direct advocacy.
Okay. So you're talking about 3,000 a year in a more typical year.
Yeah, but yeah, and there's a lot more. We train a lot more than that. Like just on supported decision making, we train. You know, that's the new probate in the new probate code. We train hundreds and hundreds of people, or employment first, or their rights, or so we're out in the community doing a lot of that work as well.
Okay, thank you. Representative Craven, you had a question, then Representative Zager.
Thank you, Mr. Chair. Thank you, Kim, for your presentation. I was wondering about intervention with the special ed population during COVID, whether that has increased for you, and also how you're managing your interventions at this time.
Thank you for that question, Representative Craven. Atlee Riley is our attorney who is our special education lead. And he just spoke to the Committee on Education yesterday and provided them written testimony on what it's been like. But as you can well imagine, we have had things switched dramatically from, I hope you can take a moment to read about, it's just 2 pages in this annual report that you have, that we were really focused on keeping kids in schools. It's such a small special education program that we had created with our partners like Pine Tree and Cumberland Legal Aid Clinic, a project by which we're just going to focus on keeping kids in school, every student all day, every day. And then boom, the pandemic hit, and suddenly everybody was being educated remotely. And of course, I've said, I think I've, it's may be tacky, but I think I've said for years that anything that adversely impacts the general population impacts people with disabilities even more. And certainly that's true with regard to the education. So we just had to pivot and start really assisting families of kids who couldn't learn remotely, or all of those. There was so much going on with that, and it's still happening. And we're working closely with the Department of Education too, on making sure that we're not all just saying all the time, we're doing the best we can, because we know we all are trying to do the best we can, but sometimes it's just not good enough, particularly for kids. And we're worried about the gap widening. So, between who gets educated and who doesn't. So it's a pretty serious concern.
Representative Zager.
Thank you, Mr. Chair. Ms. Moody, thank you very much for your leadership and for the work that you and other folks do advocating for people with disabilities. My question is regarding the audits that are done for SSDI. I fully recognize the value of being good stewards of public funds. And I was wondering if either here today or at a future date, you could share more information about the criteria for who gets audited, when, how often, that sort of thing. I'm interested in the criteria and the equity of that particular lens. Thank you.
I'm sorry, for Social Security?
SSDI, yes.
The Social Security Administration selects the people. We do not.
Okay.
They send us lists of who they have determined are perhaps risky, and they dictate that we go out and review those. We are allowed, however, to submit to them a list of who we think we might need to check out. And the criteria for that really is information coming from any one of the many other programs about a worry, like meeting a person with a developmental disability, perhaps who's nonverbal, and saying, this person doesn't look like they are very clean or in a very safe environment, or whatever it might be. And so then we might go out or we would ask Social Security for permission to review that representative payee. And then Social Security either tells us yes or no. It's kind of a weird program, but that's the way it works.
Okay, thank you. That helps.
Senator Moore.
Yes, thank you very much, Kim, for your presentation. My question would be if you could share a little bit about the funding. I think some of it's federal, some of it's state grants. So could you tell us a little bit more about how your Disability Rights of Maine is funded?
Sure. The federal grants are what are called formula grants, which means they basically come to us every year. We have significant reporting after the fact about what we use the money for, but we never have to apply for that money, which it makes it nice money. So that's DD, mental health, and all of there are 8 of those federal programs that are listed on that second page. And then the state we have contracts with. So Department of Health and Human Services, we have a contract to provide developmental services advocacy, to provide mental health advocacy at DDPC and RPC. We have a private contract with Acadia Hospital. They buy a full-time advocate from us via Acadia. We get money from Main Share and from private donors and from MEHAF, Maine Health Access Foundation, which is a great partnership. But that's pretty much it. It's federal grants, state contracts, and then other bits of money. Oh, and Civil Legal Services Commission, which is money that's on tickets that people get, traffic tickets.
You mentioned RPC. Can you explain that?
Riverview Psychiatric Center.
Okay, thank you.
And Dix.
A lot of us don't speak the HHS yet, so we're learning.
Sorry. Oh, there are so many acronyms in this disability world.
So any other questions for Ms. Moody? So we have a couple minutes left. Do you want to brag on something? Do you want to tell a great client story? Do you want to give us a real world example of a success story for you all?
Sure. I think, well, one of the things that was as you all know, that has been a huge issue during the pandemic was the wearing of masks or not wearing masks. And early on, and we are nonpartisan, and we could not get into the fray about why or when or how. We just knew early on that people with disabilities are at greater risk of getting COVID then of dying from COVID because of other health conditions that are often associated. So we took a position early on that we wanted everyone to wear masks, and that was not very popular among a lot of people. But we also did a lot of work in group homes across this state where people who it's supposedly their home, and they live in that home, and they wanted their staff to wear masks, but their staff were refusing to wear masks. It was very, very tense situations, but we stopped taking a whole lot of other cases that we had been taking and started doing a lot of mask work during 2020, which was very strange. But we found lots of people with developmental disabilities who were calling us really for the first time ever. We find we have to go out to get those cases, but calling us to say they hadn't seen their mother in 7 months, or they weren't allowed to go out to the store, and yet they see I see my staff coming and going all the time, and they won't let me go to the store. So we did a lot of that work. It is so everything all across the board, from the guy who they're taking away his electric wheelchair and he has to crawl everywhere he goes because they're claiming that he runs it into people on purpose instead of trying to figure out how to change that behavior. It's the woman who can't get mental health treatment, and we help her get it. The person who needs a new limb, to be able to work, and we help them get that assistive technology. So yeah, I can talk about Disability Rights Maine all day long because I've been doing this for like 33 years, my entire adult life, really, or most of it. Started out as an advocate, and then was a mental health program director, and then became the executive director in 1996. So it is my life, and it is the best job in the world because we get to really help people all the time.
I have one other question. Are there waiting lists for your services?
No. So people call, like I said, and they get this receptionist. We still have a physical answering, and then they get an intake. It's most people, I would say, I don't know, I should do that statistic or have intake do that statistic. A lot of people get turned away because either they're calling because their disability, they're saying, I bought a car and I think they ripped me off because of my disability, and that's not disability-based discrimination, so we can't take it. But a determination is made on their case right away. So we have a lawyer in each of the programs who that case will go to at the end of each day, and they make a determination. first on basic eligibility. Is this person eligible for one of these many lines of funding? And then merit, really, can we win this case? Can we create change for this person in a meaningful way?
Okay.
No waiting list, no.
Well, thank you for your passion and your longevity in that role. So,
Thank you.
yes, Representative Craven.
Thank you, Mr. Chair. I wonder how you resolved the issue with visiting, for example, because sometimes people serve don't understand why their family aren't visiting or why they can't go out if they can't tolerate a mask.
That's a great question, because I've known Representative Craven for, I don't know, 30 years, I think, but that was really hard, and each one was individualized. And every provider agency everybody was pivoting and trying to figure out how to do this. So every provider agency was dealing with it in their own way. And I think all of them, Representative, to a program, understood. Once we raised the concern on the part of the person, they understood and they figured out how to make it happen so that they could see each other in a distance, or this woman could go home for her birthday and see her mom or whatever. I mean, we worked together in this state so well in the disability arena during this pandemic to make sure that people really got to be where they needed to be and see who they wanted to see. So it really was different everywhere.
Thank you. Thank you again for your
Thank you very much.
Thank you.
Thank you again. We know how to reach you now, and
Okay.
we'll spend time with that colorful annual report.
Okay. Thank you.
Thank you.
Have a great day.
Next, we're joined by the folks from Maine Care Advisory Council. Ms. Del Rio, did you want to introduce yourself?
Yes, thank you. And I think I'm going to try to share my screen. Hold on one second.
It worked.
Thank you. So thank you all. Some of you know me from my normal reason I appear before you all as a member of the policy team at Maine Equal Justice, but today I am here representing the Maine Care Advisory Committee, and appreciate the time that you're giving us to talk a little bit about what we do each month. The Maine Care Advisory Committee is a committee, every state has one. There's actually guidelines under federal statute about the need for those, and kind of laying out what the purpose is and who should be a part of it. Here in Maine, if you're really interested, you can look at the rules in the Maine Care Benefits Manual in section 1 and learn more about the actual details of our committee. But basically, our purpose is to help advise Maine Care Services and OFI when it comes to issues around the provision of services through Maine Care or member access to services through Maine Care. So we focus a lot on policies and talk about if the department is looking at new policies, if we think there might be any implications that they haven't considered or things that we hope that they'll think about. We talk a lot about issues like rates and provider enrollment in the program, member eligibility and enrollment in Maine Care, all of those things. It is an advisory group, so we don't actually have the ability to dictate what the department does, but the department, hopefully we see each other as partners who are trying to do what's best for everyone so that people can get the best service that they can from Maine Care. The membership of the committee is made up of both representatives from provider groups and people with expertise around the provision of healthcare services, and then also Maine Care members themselves, as well as representatives like myself who represent Maine Care members. And I won't go through all of this right now, but if you are interested, you can see the wide range of expertise that's a part of this committee. And I'll just say, as someone who's relatively new to the MAC, I started going in 2018 and have been the chair since 2019, that I am just, every single month I am impressed by the depth of knowledge and the commitment to healthcare of all the people who are a part of this committee. It really is a place where you can learn so much about what's happening across so many different sections of main care, and different issues that come up that I wouldn't necessarily come across in my everyday work. So I'm really appreciative of all of that knowledge that people are willing to share. I'm the chair, as I mentioned, and our vice chair is Gia Drew from Equality Maine. We're elected annually by the MAC members. MAC members serve 3-year terms, but those terms, they can continue to serve additional terms after their initial term. We kind of reconstituted the committee in August of 2019. So almost everybody who's a part of the committee now joined then. There's a few exceptions. And then we'll serve 3-year terms until July of 2022. And just a note about the chair and vice chair, that it is in rule that we should be representing members. So that's why those positions are held by people from organizations like Maine Equal Justice and Equality Maine. We're member representatives. There's also great staff support from DHHS. Lisa Weaver is assigned as the staff support person. She takes notes, helps us gather the materials we need for meetings, make sure we have all the technology right now that we switched to Zoom. But also many other staff from the department participate in our meetings, including Director Probert, folks from OFI, people with lots of different expertise depending on what the agenda items are any given month. So we really appreciate that, because we couldn't do our work without that participation, because we really need to know what they know in order to figure out where there might be issues or places that we could do better. And there is a place where folks, whether or not you're a MAC member, can see what we've been up to. We meet on the first Tuesday of every month from 10 to noon. Those meetings are open to the public. We used to meet at the DHHS offices in Augusta, but since April, we've been meeting on Zoom. But anybody can get the link to that meeting if they want to participate. And if anybody has any questions about that, feel free to reach out to me anytime. I included this piece about regular review of policy developments, because one piece that's in rule about what we need to focus on is policy developments that are happening. So each month we get a packet of information from the department that includes where any, like what the status is of any proposed rules, rules that have been recently adopted, rules maybe that have just been put in place as an emergency, even rules that are like in consideration to be proposed, and then also updates on the status of any waivers and state plan amendments. So as I know you've been getting lots of orientation to DHHS over the last couple of weeks, all the different sections that you've heard from, there could be rules from all those different sections in that packet. So different people and organizations who have expertise in those areas will ask questions. They might suggest that the department consider other places where there might be needs for rulemaking, or questions about waivers, things like that. So that's always something on our agendas every month. But we talk about lots of other things as well. So I went and looked at our last 3 months worth of agendas and just picked some of the topics, so you have a flavor of like what we do. We always are getting updates about COVID, given what's happening. And I will also note that at the beginning of the pandemic, we also spent a good chunk of time each month sharing from organizations and members with the department about the challenges they were all facing. So I hope that that was a helpful place for the department to really hear what's going on the ground, so that they could help figure out what needed to be responded to by the department. We've also talked about things like data, or as you've all heard, the rate system evaluation process. That's a big topic that's been a standing agenda item all year. Things like Section 28 services or electronic visit verification, the COVID vaccine rollout, like you all heard earlier today. All of those areas are things that we might focus on. Those agenda items come both out of each month. If there's something that comes up that we think we need to have further discussion on, I'll flag it for the next month, but also any MAC members or even the department can suggest items for the agenda. We also have subcommittees that can be formed at any time. They have to be chaired by a MAC member, but they don't have to only include MAC members. And those subcommittees focus on different things, and they can share concerns or updates with the committee as needed. So some share every month, like the rates subcommittee. Some only come when there's something that they really want to raise. And so examples of those, in addition to rates, we have a new committee focused on dental services and access. There's been subcommittees focused on provider communications or member access. Last year, we had an ad hoc committee that formed around a school-based services rule that the department had proposed, and there were some concerns by MAC members around how that was going. And so like they asked to form a subcommittee and quickly convened and did a lot of work in a short period of time. So the subcommittees, some are all the time and some are as needed. And in terms of our powers, if we do want to officially do something like, if we were, for example, wanting to weigh in on legislation, which we very, very rarely have ever done, we would need to do that with a vote of the committee, and there's rules around that. Also, if anybody on the committee, like people can mention that they're a part of the committee, but you can't make a public statement on behalf of the committee without a vote having been taken first and with the permission of the chair. And it's also important that we always are clear that like our role is advisory. So the department is not subject to what we say. And that's really what we are and what we do. And if you have any questions, I included my email address in case you wanted to follow up, but also I'm happy to answer any right now as well. And I'll stop sharing too.
Thank you. So are there any questions for Ms. Del Rio? Yes, Senator Moore. We're not hearing you. Senator, you're still on mute.
There we go. Yeah, I clicked it twice. That's what happened. Kathy, thank you for being here and presenting to us. We enjoy having you in person rather than on the Zoom, but thank you for that. My question is do members of the committee get any kind of stipend at all for their time? No.
Well, almost no. All of us who are like representatives of an organization, we don't. We just do that on a voluntary basis. But for people who are actual main care members, recognizing that one of the reasons they're a main care member is they have low incomes, and that like asking them to give their time for this is a commitment they're not getting paid for. Like I'm getting paid to be there as an employee of Meaningful Justice. Yeah. So those individuals do get a stipend for their participation in the actual meeting. And also like they can get reimbursed for mileage and things like that when we meet in person.
That was my concern. That's good. Thank you.
Yeah.
Are there other questions for Ms. Del Rio? Thank you for those points. Thank you for your work.
Thank you all.
Glad you could come. So our next guest, I think I see April Kerr having checked in, and she's here to talk about the Consumer Counsel System of Maine, if you're still there.
I am, and Simone Mallon is our wonderful executive director. I think she's going to start.
Welcome.
Well, thank you for inviting us to come to your orientation. Good afternoon, Senator Claxton, Representative Meyer, and wonderfully esteemed members of the HHS committee. I'm Simone Mallon. I'm the executive director for the Consumer Counsel System of Maine, and I am a peer myself. I identify as somebody with lived experience in both mental health and substance use recovery, as do all our members of our organization, our staff and our board and local council members. And I am here with my amazing board chair, April Kerr. And we wanted to just give you sort of an overview of the Consumer Counsel. We sent along an electronic copy of our presentation, or information, I should say, and we are going to mail these to you, hard copies, because there's no way to put pens and Post-its and all those things that you need in a digital copy. So we're going to send you a hard copy, as well as a few things to help you in your work. So those will go out at the end of the week, I believe. So the consumer counsel system in Maine was really born out of two places. One is the broader peer community. And I will say, many people have a different title. Consumer is one title, peer is another title, lived experience is another title. And then there are many that also identify as consumer survivor ex-patient movement, and that's the way they identify. So there's lots of titles and ways to identify ourselves, so it can get a little confusing, but they pretty much all mean the same. So we were born out of the greater community of consumers and peers, wanting to have greater voice in public policy. And at the same time, it became part of so there was a group of consumer leaders, myself was one of them, that worked from 2004 and 5 to sort of frame out what a council might look like, an organization like ours would look like. And then it was also written into the 2006 consent decree plan. So it was a merge of the desire of the consumer community as well as the consent decree that really brought those pieces together for us and created our organization. We then in 2008 were put into state statute by the 123rd legislature. And we have included our statute in your packets. The purpose of the council is really to bring forward the voice of consumers of adult mental health services to the legislature, to state government, to really, and it is a unique way that we do that through the creation of local councils that exist around the state of Maine, and to have feedback from the grassroots of the community to inform the work that we do at a statewide level. So all the local council members elect their representatives that sit on our statewide consumer council. The statewide consumer council is our board of directors. And so that information flows from the statewide level to the locals and vice versa back to the locals, so that we are giving you and state government and all the people that partners, I have one of my employees, we have 5 employees, and one of them is on the MAC. And then I saw Kim with you guys just a few minutes ago, and I'm their board president, and I chair their mental health advisory committee. So we have lots of partners that we do this work with. But really our responsibility that we take very seriously is to try to bring forward the voice of people who use public mental health services to all the places to help inform that. Because historically, seats at the table were not given to people who receive services. So that was really the point of our creation and our work today, up to today, and will continue, I hope, for a very long time. April, do you want to maybe talk a little bit about local council and how you've learned a little bit about this legislative process and what that's been like?
Yes, I'd love to. First of all, I just like to say thank you for the chance to meet you all. Some I see familiar faces. That's wonderful, and I hope to gain a familiarity with more of you as we, that's one of the things that I wrote in my couple of notes I had was our main goal, working together to help bring a collective voice to you all, so you can help you make a better informed decision as you go through the many things that you have to make decisions in. I just want to say about 5 years ago when I first came to this council, I was not one to step up and speak up. I didn't dare to. I didn't know that my voice even mattered. I didn't even know anything about all you wonderful folks in legislature and that we can communicate with you all. But when the Section 17 services major change happened a few years ago, and there was a major outpouring of people from the community to come in and testify on that, I came. I was one of those people. That was my first time of experiencing this different view of how things work. And it was a major eye-opener, very terrifying one, because I thought I was so well into my recovery with my anxiety disorder and all this stuff. I was doing great. And then I step off that elevator and into that hallway with over 350 people just talking. And I was even saying it now, I'm getting a chill. I was so drawn back. I was like, wow. I literally turned around and was like nose to nose with the wall. Thank God my husband was there. Simone was there, who I didn't know so well as I do now today. And she supported me. But anyway, you know, this is the kind of thing that happens with people who receive services to help them become functioning people in their communities and in their lives, is they don't understand. They don't know that their voice matters. And that's what we work toward doing, you know. In the Farmington Council, she said, she mentioned about local councils. Well, I represent the Farmington one, as well as I'm the chair of CCSM. And we've been trying to gather information, but also bring information to the people in the community and teach them the different ways that they can learn how they can share their voice, either through us or through, you know, you have new avenues now, having this YouTube channel. That's been amazing. That's going to teach a lot of people. That's really great. I'm so glad to see that. So like I'd started to say, in the Farmington Council and some of the other councils, we came together and we did a workshop just this past week to try and educate people of what it looks like to bring a testimony, your voice, to legislation and share it and help you people. We tried to do an informative thing, although it kind of got twisted and turned with this whole COVID and doing things on Zoom. But I think we did the best that we could with what we had at the time. But again, our main goal is helping you all. We work together as a team, and we're hoping that we can help you all in many ways throughout this session. Thank you for the chance again to speak to you all.
Thank you, April. I wanted to just walk through our packet that we sent for you guys. And I really want to, I want to say when COVID hit, we had started doing public forums to really have additional feedback to our whole system of body of advisory processes. And so we have been doing a lot of forums online on Zoom. We've also, as well as all our meetings, we haven't missed a beat. We've continued to function remotely. Today I'm in the office, but most of the time I work from home, and we're teaching a lot of people about Zoom. And early on in the pandemic, we spent a lot of time working with all the mental health peer support recovery centers across the state and other groups as well, to learn how to, you know, they're all a drop-in resource and they have never done anything with technology. So we did a lot of work to help people understand technology, gain access to technology, and understand what the heck is this Zoom thing anyways. And that has been no easy feat. And it also has raised really an important thing for us. And, you know, I've never thought I would become a broadband advocate, although I think broadband is incredibly important, but it has showed us how much more important that is when you're in a disparate community. And so many people don't have access to technology or free Wi-Fi or any Wi-Fi and can't afford for all of this stuff. So we are disconnected in some ways from pieces of our community because the reality is not everybody has access. So one of the forms that we did, I've given you 2 form documents, but one of the form documents we had professionally written into a report, and it's called Reimagining Maine's Adult Mental Health System. And it's a 20-page report for you all that we had done. It will go to a lot of places, but you are getting to see it before anyone else because we just finished it. This was done in October of 2020, and we really wanted to know if, I took a playbook from Senator Claxton and I said, if you had a magic wand, how would you re-envision what we have in Maine? And so in that report, there are 9 areas of major conversation. First is housing, second is empowerment, and that includes a lot of things: immediate care and medications, support systems, alternative therapy, prison and jails, systemization of care, the consent decree, and employment opportunities. And so I won't go through those 20 pages, but I would really impress upon you that there's a lot of great information and research in there as well. And then we also did a forum in May of 2020, and what we've done is we've done some topic specific forums like we did last year. We did a whole series around the state around the consent decree and what does that mean for consumers and the potential changes to that, because there was a lot of misinformation out there, and we partner with DRM a lot around that issue and a lot of other things. But we also do these open forums where we ask, what is going on in your community? And so the document, often we make it the way that we give advice to the department. In our statute, there's a formal way, it's called an issue statement. And you have some issue statements in that packet as well. But we use that format of what's the issue, what's your experience with that issue, what are your recommendations, and what are your expected outcomes. Sometimes people were able to give us all of those pieces, but sometimes not. So we document it all because it's important information. And the May one is by area. So you'll see stuff for Augusta area, all the different locals, and then we had an open one for anyone that wasn't able to make it to anything else. So, and then behind those form documents are copies of issue statements that we've worked on in the last year and a half. And lots of stuff going on in the community. And so I think our most recent issue statement is around telehealth and the importance of telehealth. And then there's a reference, there's a little bit of a reference list if you want to understand a little bit more about recovery and some of the terms we use, including good old Maslow's hierarchy of needs, because that is so critically important in life to understand, because it just is. So what are my last thoughts? So I have 2 last thoughts before I'll open it up for questions. One is that we want to be a resource for all of you, and not just, obviously we spend most of our time in Health and Human Services Committee giving our thoughts and feedback and helping people come and tell their stories that impact in the ways that impact what you're debating. But we are in other committees as well. We are an amazing resource for all of you guys, and also to the people that are your constituents to be involved in having a voice in public policy. And I know it's scary for a lot of folks, as April really clearly was able to share. but it is vitally important that our voice be at the table with all of you, with the department and other entities to really partner together to make Maine's mental health system the best it possibly can be. And then the last thought I want to say is we don't want more buildings and institutions. We want people to be fully engaged in their communities of choice and have everything they need to be able to be successful in their communities. And now I'm going to stop. You're muted, Senator Claxton.
Representative Zager, would you like to ask a question?
Thank you, Mr. Chair. I would just like to actually commend and thank Simone and April for coming. Ms. Karras, especially, I appreciate you sharing a bit of your journey. It is very helpful. And also it's a important reminder, the way you said, I didn't know that my voice matters. That is an elegant way to summarize the entire American enterprise for the last 250 years. Thank you very much for coming.
Thank you.
Representative Craven.
Thank you, Mr. Chair. Thank you both for being here. My question is about the consent decree. Last year we had a bill in front of us that I found kind of disturbing and not sure where it was going to land. And I wonder if you know if there's a similar bill coming this year.
I would be glad to answer that for you, Representative Craven. There is not another bill coming. There's actually been an agreement between the Disability Rights Maine as the plaintiff's attorney and the department that they have entered. The ink is dry, but it's just like a week dry. So it is brand new, and if you don't have it already, I am more than willing to send it. Well, where it is right now is Judge Wathen has sent the recommendation to the court, and I believe we're just waiting right now for the court to then process it.
Would be great to have a copy. Thank you.
I will send that to Carrie. I will let you know the private right of action did not make it into the final agreement. Really, there's a set of core standards the department has to meet for so many quarters in the next 2 years, I believe, in order to be in significant compliance. It also includes, and the standards were important to me, but the thing that was vitally important to me was they are adding 3 Disability Rights Maine advocates. And I believe they're going to be housed in the department in the 3 regions. Because here's the thing that I struggle with all the time. I hear somebody stuck in, you can make a long list of where people get stuck in the system. And then it's like, sometimes they call me, they call DRM and all these places, and there isn't a centralized way to say, I'm stuck with X, Y, and Z. I can't get into a service, a provider, blah, blah, blah. I can make a long list. And I want to give them somebody concrete that is going to help them get unstuck and get the grease moving on the wheel. Because I think that in the end is what really is going to help people. The consent decree in this last decade or more hasn't really been able to help consumers on a one-on-one basis. They've needed, it all has to be systemic. And while systemic is important, obviously why we exist too, but in the moment, if somebody doesn't have what they need and doesn't know where to go, that's my heartstring struggle. Is what do we then do? So I want some people willing to get dirty and do whatever it takes to make those phone calls and get somebody into wherever they need to go. So that was the piece that was my line in the sand. Did not want to lose that in the consent decree discussions. And so that has remained in there.
Thank you. Representative Madigan?
Thank you, Senator Claxton. Thank you, Simone, for being here today. I guess mine's more of a request. I know that in my area, the Consumer Council has a monthly support group that I assume has been on Zoom. And I'd just like to kind of put it out there too, that I'd be more than willing to kind of talk with that group, local group, to find out what's working and what's not working and kind of get some feedback from them about what would be helpful and how both myself and the committee and other folks can be helpful with folks who are mental health consumers.
Thank you for that offer, Representative Madigan. That's really important. Just so you know, Waterville has currently disbanded due to lack, and it was before COVID. Many of the members were struggling, and so we didn't have enough of a group. But and that has happened to different parts of the states at different times, and that's okay. And we can recreate and rebuild as we do outreach to provider organizations and other consumer groups. We start locals where there's the interest, and then we'll continue to work with them and try to bring people in. It was not long before COVID started that I think Waterville really struggled, and so we need to do some rebuilding in there. But I will certainly let you know. There's a new the Peer Center in Waterville has a new director, so we have plans to sit down with her virtually and maybe see if we can get something started in Waterville again.
Thank you.
Representative Silver?
Thank you. Thank you, April, and thank you, Simone, for the update, especially about the consent decree. If you remember last year, we had Senator Gratwick, who always asked guests, what keeps you awake at night? So I just would like to know from the consumer's perspective, given COVID, given some of the restrictions we've had because of COVID and other things that have affected delivery of service, what are if you had to name something, what would be the thing that I'll let each of you answer, that keeps you awake at night?
For me, it's lack of housing. And that is probably, there's all kinds of subsets under that of problems with, getting a BRAP voucher and then finding, affordable housing and discrimination. There's like probably 20 subsets under that. But for me, if you don't have housing and stable and secure and safe housing, you really can't work on your recovery journey. And so that's why we include Maslow's hierarchy of needs. If you do not have food, shelter, clothing, you can't move on up that hierarchy. So, and there's just been so many issues with housing. I'd have to put that first.
Thank you. I appreciate that. And April?
I just would like to say that even though I feel that is very important, and I recently, as many have in the recent past year, experienced no heat, no electricity. So when you go into that mode of, oh, how am I going to get my heat? How am I going to stay warm? We need shelter, but like Simone is saying, if your basic needs are not being met, then you're just in survival mode. You're just focused on that, and trying to think past that is impossible. And when I didn't have heat, I didn't even realize I was in survival mode until it was done. So being connected, I think, is the thing that has kept me awake at nights many times, and knowing what are are my friends, family, others maybe that are my neighbors, are they safe? Are they having their needs met? Has been the thing for me.
Thank you. I think those are things that, as we go forward, we have to really consider for people who are out there struggling every day. So thank you very much.
You're welcome.
We're glad you could join us, and so we could hear your voices. So
Thank you.
Good luck with your journeys, and we'll feel free to contact you and look forward to the mailing when it comes.
Thank you for having us. Appreciate it.
Yes, thank you.
The question about housing is quite timely in that the next group we're supposed to hear from is the statewide homeless council. So did you guys choreograph this?
No, we did not.
So
It's Stephanie from the statewide council, everybody. And I just, before Simone and April leave, I just wanted to say kudos, and I'm right with you on the housing and basic human needs and Maslow. So thank you for that.
Welcome.
And thank you for the work you're doing.
Thank you, Stephanie.
Yes, thank you.
And welcome, Ms. Prim. Glad you could join us. They set you up nicely.
Yes, they certainly did. So good afternoon to all of you. It's a privilege to be here. Senator Claxton, Representative Meyer, and honorable members of this important Health and Human Services Committee. So I am Stephanie Prim, and I am the chair of the Maine Statewide Homeless Council, as well as the executive director of the Knox County Homeless Coalition. That is a shelter and homeless service provider in Rockport and Rockland, Maine. And just echoing what everyone else has said, thank you so much for this opportunity. It was so encouraging to be asked to be here today, and to know that the critical and increasing challenges surrounding homelessness in Maine are on the radar with all of you. Perhaps a gift of the pandemic that we've all been navigating together. And I really wanted to start by saying, on behalf of the statewide council, I wanted to take a moment to thank our partners and colleagues at CDC and DHHS and Maine State Housing Authority for their incredible support and partnership during the pandemic. Without their help, many more lives would have been lost than have already. Together, we have pieced and patched and taped and learned, and it is the learning that has shed light on the crucial need for systemic change in Maine's homeless response systems. So my first task when you all reached out was to explain the council. Maine Statewide Homeless Council was officially formed during the Baldacci administration. Council was given proper resources at that time to support nominal staff and initiatives and activities to meet their charter. The chair was, from what I understand, a cabinet member focused on housing and homelessness. During the LePage administration, the council was defunded and a different set of priorities overshadowed its important work. For the last few years, council has focused on building back engagement and participation of key partners and organizations. This has been in an effort to bring a trustworthy, experienced body to the informing of the planning and policy and funding decisions that you all are faced with to improve and strengthen our state's homeless response system. Today's council includes and represents over 57 organizations that are serving critical roles in our state's efforts to save lives, protect the public health during the pandemic, and ensure that every Maine family has a chance for a safe, warm place to live, food on the table, access to critical health and mental health services, and hope for a bright future for their kids. Participants and members cover a wide range and include shelter and service providers in the state, DHHS, Maine Equal Justice, corrections, CAP agencies, Veterans Affairs, legislative partners and representatives, behavioral and physical health organizations and foundations, USICH, United States Interagency Council on Homelessness, another acronym for you, HUD, and so many more. And council, just so you know, is also well cross-pollinated and communicative with the Maine Continuum of Care and the Maine Shelter Network. We are an all-volunteer and currently unfunded organization, pure in our professionalism, passion, experience, intent, and efforts to bring solutions to homelessness in Maine. We're here to inform you and to help you make the tough decisions that you're faced with, to ensure that homelessness in Maine is rare, brief, and one time, and that Maine has enough affordable housing, supportive housing, shelter, and support so no Mainer is sleeping outside tonight in Maine. Our number one focus, other than supporting one another as peers in the continued navigation of the pandemic and related public health issues, is in the development of a simple, implementable plan to strengthen our homeless response system in Maine. The plan will recommend appropriate resources and coordination are in place to support our homeless shelters and service providers, development of affordable and supportive housing, and advise on many of the changes needed to entrenched programs and systems that can be greatly improved simply by re-examining and shifting certain aspects of them. Our planning has a special focus on the rural areas, many of which are and have been without any services and support for a very long time. We're halfway through our work. The plan is due to be done midsummer. Also important for you to know, our planning and efforts are firmly grounded in the collection from available but often disparate data systems and data points around gaps and needs that exist in our state. And they are being augmented with significant qualitative informing from key constituents. So what is the statewide homeless council structure? The statewide council is informed by 3 smaller regional councils so that we're ensured of being informed about the local and regional needs, gaps and needs around the entire state. The original charter called for and still consists of 14 official members. 1 member appointed by and representing the office of the governor serves as chair. 6 members appointed by the governor, 2 from each regional council. 3 members serve as regional chairs and are appointed jointly by the president of the Senate and the Speaker of the House. I'm happy to email your, I think it's, is it Carrie, the original charter, if that would be helpful, and I can send you a copy of this as well. In addition, there are 4 directors and commissioners or their designees. So Director of Maine State Housing Authority, Commissioner of HHS, Commissioner of Corrections, Director of the Bureau of Maine Veterans Services. So that's really the basic structure. And we have participation of, again, about 57 organizations and representatives therein at every monthly meeting. And then there are regular meetings of the regional councils, plus additional work groups attached to the work with the Corporation for Supportive Housing that we're doing in the planning. I guess if I had one favor and request of this wonderful committee, it would be to grant a few key members and participants of statewide council a work session. I think what I find so often is what some of the contributors today have already mentioned, is that there's really a need for the sharing of challenges and opportunities and information amongst and amid all of you and amongst the key service providers in the state, so that we can do a better job assessing what already is and maximizing what already is, and then making change where needed. And I wanted to just briefly touch on what our homeless response system looks like today, because I think COVID has shed light on it, and we're so grateful for that. But pre-COVID, I think nobody really understood it. The shelters are a critical part of the underpinnings of our healthcare system, our behavioral health system, our substance use disorder system. And now we've seen firsthand that shelters are a critical part of the public health systems. Maine shelters are run by, I'm going to use the word intrepid professionals. They're a collection of independently run organizations. Many of them are in rural areas struggling to tape and patch things together to save lives. The shelters are a catch-all for everyone with nowhere to go, a stark reminder of the need to strengthen the public health system's capacity to respond. Shelters catch discharges, referrals, and knocks on the door from corrections, crisis units, hospitals, community members, churches, victims of abuse and domestic violence, families who've simply been sleeping in cars with their kids after losing a job. We provide not only shelter, but solutions, comprehensive care, and support in the process of getting a person experiencing homelessness back on their feet into the programs that they need to have hopeful, productive lives. Many of us also independently just provide, wherever we can, critical support services like food and now outbound delivery of food, personal hygiene supplies, and now at-home learning supplies to keep the families together and moving forward. Transportation, mental health support, and also financial assistance. Our organization will pay to repair a window to get somebody into an available and rare apartment. So again, what do we need? A stronger homeless response system with shelters at the forefront. Capital and services funding is critical. Affordable housing has already been mentioned today, but I cannot say it enough. Without stability, people cannot move forward in their lives. And sadly, we're seeing such an exponential increase in need, even with moderate income people, older folks, people on fixed incomes. This is not about the preconceived notion of what homelessness looks like. And we need supportive housing, which also my colleagues prior have mentioned. We need to be open to unwinding, examining, and simplifying some of the well-intended and well-funded programs that do exist and make some changes that allow them to work better by informing them with people that are doing this work directly with clients, and get back to client-centered care. So much of the challenge that we face is about eligibility, accessibility, and coordination of some of the disparate but very solid programs. If someone engages in one program, sometimes it really dramatically negatively affects their income or their ability to move ahead, and unbeknownst to the provider or the program. And again, I ask if it's ever possible to convene a work session with you all and with a few of the key players in the state. I think that might really be helpful. So that was, I don't have an annual report because we're not a funded thing, but I hope this was a helpful start. And I welcome any questions or follow-up that would help you. And thank you again for all you do for the state.
Thank you, Ms. Prim, for being here and helping us learn some more about your efforts. Can you give us an example of some of the barriers that are out there for people getting the help they need and how convening some group might help?
So, as you all know, so many of the departments that are engaged in everything that is so important to improving homelessness, like main care, for instance, mental health services and access to them. I actually found out from one of our clinicians last week that the rate of reimbursement for clinicians as per main care is something like $57 an hour. And in addition to that, there's a lobster boat full of administrative overburden and paperwork. And so what we find in our boots on the ground work with our shelter and services organization is that we can't find any spots, especially for our teens in our youth program who desperately need to get that access to mental health support. And that is extremely frustrating. So I think adjustments like that, I think adjustments in some of the existing funding streams, one of them is we get reimbursed for very specific but often limited case management services. And the services that are reimbursable and are dictated by that funding stream, which is Section 13, comes through DHHS. It's for homeless case management. Those requirements can be very limiting to our capacity to maintain that trust-based relationship that moves that family, that whole family or client forward. And so one of the hopes that I have is that we can open that up and look at how it's working and allow for a little more latitude in what we can do and what we are allowed to be reimbursed for.
Okay,
Is that helpful?
That's helpful. A little bit more specific. Thank you. Representative Connor, you had a question?
Yes, thank you, Mr. Chair, and thank you, Ms. Prim, for the briefing. I appreciate it. Two quick questions that I have is I've read varying numbers statewide. It seems like a different agency has a different total, and so I figured you guys would probably be the experts. But what is a very good, accurate number of homeless in the state of Maine? And then my second question is you had stated that the Baldacci administration funded the council, and then the LePage defunded it. My question would be, has the current administration looked at funding it, or has the question been asked of the current administration to fund it? Those are my questions. Thank you.
Okay. I thank you for your questions. That is top of mind for me in terms of hopeful refunding of the council so it can better address the issues that it needs to. I would love to present that and put that forward. It's been a thought, but we haven't taken action because there's so much else on everyone's plates with the pandemic. But that would be incredibly helpful in moving us forward. In terms of the numbers, some of you may have seen January 29th, which was last Friday, there was an article in the New York Times about homelessness. And I think the title was something like Homelessness in America, and nobody really knows how big the numbers really are. And I'm happy to send to Carrie, right? I can send Carrie the current numbers for you that are really the best numbers are available through the HMIS system that resides with Maine Housing. But one of the challenges in Maine, especially in rural Maine, is really getting an accurate count of homelessness, because the methodology that has always been in place, another sort of entrenched methodology that I believe was directed by HUD and that we are required to participate in as part of our funding that comes into the state through the continuum of care, is called the PIT count. You may have heard that, another acronym, a point in time count, which happens in January overnight in Maine. And so if you just think about the reality of that geographically and from a meteorological standpoint, and if you factor in the fact that so many of our homeless folks are hiding in the woods and in sheds and in uninhabitable places, we can't find them and we can't identify them. And so I will send you the current counts, and I can send you the 2019 counts, but it is an unreliable number, and I'm certain that it is understated. And I can also send the link to that article because it was really eye-opening, and the New York Times really affirmed what we run into all the time here in Maine, which is that it's a national problem.
Thank you very much. That's all I have, Mr. Chair.
Thank you, Representative Connor. Any other questions for Ms. Prim? We'll thank you again for being here, and thank you for sharing some of those insights and for your ongoing work.
Thank you all very much.
Now we're being joined about the statewide coordinating council, and Kaylee Hess is here.
Yes, hi. Thank you so much for having me today. So Senator Claxton, Representative Meyer, and members of the Committee on Health and Human Services. My name is Kaylee Hess. I'm the chair of the statewide coordinating council for public health, and I'm also the associate director of the Partnership for Children's Oral Health. The Statewide Coordinating Council for Public Health, which I'll just call the SCC because it's a lot easier, is a representative statewide body of 23 public health stakeholders that's established by statute to support the Maine CDC with collaborative public health planning and coordination. The SCC was established in 2000 out of the 2005 Public Health Work Group, which was about 40 people who were appointed by the governor at the time, and they were charged with developing and strengthening our public health infrastructure statewide. And the key elements of what they came up with were codified into public health statute. These key elements included establishing the SCC, which I'm speaking on behalf of today, 9 public health district coordinating councils, which there are 8 regional councils and 1 tribal council, sorry. And these are largely volunteer representative bodies that help with collaborative planning and decision-making for public health issues on the district level, the public health district level. It also established local public health units in each public health district, which are staffed by the Maine CDC. So public health nurses, health inspectors, epidemiologists, and district liaisons, which help with the regional communication, coordination, and system performance efforts. The work group also established the Healthy Maine Partnerships, which were comprehensive community health coalitions that functioned in a public-private partnership manner to serve every town in Maine with core public health services. And they also, the last element of this strengthened system was to modernize Maine's local health officer system. So under the prior administration, Maine's public health system was weakened. Funding from the Fund for a Healthy Maine was funneled into Maine Care. Grants to address public health concerns were actively not sought out or were turned down when they were received. There were news articles about the colorectal cancer screening grant that we turned down, for example. And contracts to the Healthy Maine Partnerships were shifted in ways that resulted in many of these organizations being unable to stay open and provide core public health services to towns across Maine. And this all resulted in a loss of capacity locally and statewide that we're still feeling the effects of today. And I share this history, I know I'm speaking just on behalf of the SCC, but I share this history because it's super relevant to the current situation that we as a state find ourselves in with regards to public health in the middle of this pandemic. So Maine's public health infrastructure and our ability to be responsive at the local level has been a frequent concern among SCC members at our meetings over the course of the last year. So per statute, the SCC is charged with helping with our public health accreditation as a state and assisting the Maine CDC with planning for public health services so that they're provided statewide in a way that's effective, efficient, and evidence-based. And we also do what we can to support the tribal public health district as needed. We do have a report that we have to submit annually. We do have CDC support to help run this group. But we're all volunteer members, but we did submit our annual report. And I noted in it several concerns that have arisen over the course of the year, which are obviously quite relevant with regards to the pandemic and public health in Maine. So I wanted to reiterate them. So how do we address racial disparities related to COVID-19? The SCC is concerned that our current data collection and systems assessment efforts in the state, public health systems assessments efforts in the state, might not be designed to best capture racial health disparities in the state, which obviously, as the hearing for LD2 is going on, is something that we all need to be keeping front and center. We're concerned about making sure that we get consistent and accurate public health messaging to all community members. Concerned about youth mental health and supporting education during this time. We're concerned about increasing food insecurity. We're concerned about losing ground on the opioid epidemic and being able to continue to meet the needs of people with substance use disorder or who are in recovery. Transportation barriers, which are essential to maintaining health, are just getting bigger with the pandemic, as is social isolation among older adults. And we're really concerned about the need for more support for local public health infrastructure. And we're concerned about the capacity of the Maine CDC to keep progress on other public health efforts as they arise due to the obviously huge challenges of managing the public health response to COVID-19 as well. So we only meet quarterly, so this is by no means a comprehensive list of everything that we want to work on in the state. We really aim to support the Maine CDC. We've developed polling to help figure out local vaccine concerns and opportunities with regards to the COVID-19 vaccine. Members of the SCC staff public health work groups related to core public health systems efforts. We really aim to be local sources of accurate information in this age of misinformation related to the pandemic. And we do all this work so that Mainers can be assured of good public health efforts in the state. But I did want to take this opportunity to remind this committee that Maine's public health infrastructure was under-resourced before the pandemic hit. And with COVID-19 ravaging our communities, other public health issues are only getting worse. And the FCC is really concerned that we simply do not have the capacity at the state or local level to address these concerns. And we see this popping up. So for example, gaps in local infrastructure have become more obvious as we've seen ad hoc volunteer coronavirus task forces emerging across the state to meet the local needs of communities. And statewide, over time, Maine CDC has lost leadership in very important programs. For example, several years ago, the Office of Health Equity was dismantled, which poses real challenges to address the racial disparities that have been exacerbated by COVID-19. In my work, I do work in oral health, and the oral health program at the Maine CDC has been dissolved, threatening oral health outcomes among many members of our communities, particularly children. And this has been made worse by the pandemic and lack of statewide coordination because of that lack of capacity at the state level. While these are only two examples, we also know that Maine CDC employees and subcontractors have been redeployed to support pandemic response efforts. And while this is absolutely an all hands on deck response, the fact that these staff have had to be deployed underscores the need to rebuild our state health department and our capacity at the state level. And this investment is necessary to meet the challenges of the pandemic now and the challenges that we're going to see in the future. It's really easy to get caught up in all things related to the pandemic, especially in public health. And I would encourage everyone here to remember that the pandemic is only making other public health issues worse. Without constant vigilance and investment in our state health department and support for all areas of public health, we can expect backslides, risking the health of the most vulnerable people in our communities in areas like tobacco control, reducing youth substance use, preventing suicide, and other topics that I know are close and dear to all of us. I will say that Maine's public health workers have gone above and beyond during the pandemic. These are people you don't hear or see very often. A lot of people regularly work 60 to 80 hours a week and volunteer on top of their full-time job in their communities because they know that their assistance is needed and they work for a cause that's more, higher than any of us. But this is really not a sustainable approach to meeting Maine's public health needs. So I would also like to take this opportunity to remind this committee that the data regularly shows that investing in public health is sound public policy and results in lives saved, quality of life improvements, and huge cost savings down the line. So we do have a report which I submitted. I'd encourage you to read that if you haven't done so already. It's only 6 pages, it's pretty fast. And I'd like to thank you for your time and for your attention to public health and over the course of the session, and I'm happy to answer any questions that folks have.
Thank you. Thank you, Kaylee. Appreciate that. Do I see any hands for questions about the SCC? Can you speak a bit to how you're funded?
The SCC, I'm not sure. The SCC doesn't have money. The district coordinating councils also don't have huge buckets of money, really. So a lot of the people who volunteer to be part of these groups are volunteers. The Maine CDC has been very gracious to provide administrative support to help us continue to meet. Even, over the years, we've continued to meet at varying levels of support and ability to do much from the CDC. But we don't have funding.
And do you have legislation that would address that or change that, or just crossed fingers?
We don't currently, although I would say that a lot, I mean, obviously from the last person who was speaking too, there are a lot of people who are volunteering a lot of time to be part of these committees that are legislatively mandated. And one thing as we're thinking about equity moving forward is how do we ensure that we have equitable representation on these committees? And something that's been top of mind for me is that perhaps stipends for people who might have difficulty being on these committees.
I'm sorry, you're breaking up.
Don't have. Oh, I'm sorry.
Yeah.
We don't have funding as a committee.
Okay.
My internet connection is unstable. Can you still hear me?
Yeah. Can you stop your video? We'll be able to hear
Sure.
you.
Yeah.
There we go. All right. Are there any questions for Ms. Hess? I don't see any, Kaylee, but thank you for being here.
Yeah. Thank you for having me.
We'd certainly be more than willing to hear if you had something to offer as far as legislative funding requests down the road.
Yeah, I guess the thing that I would leave you with is that, like I said, investing in public health is very strong public policy that results in cost savings. And I know that public health across the board has been hit really hard for this during this pandemic. So I would encourage you, as public health related issues of any sort come across your desk, to really consider them carefully and consider it an investment in our overall improvement and well-being as a state and financial improvement as a state.
Very good. Thank you for that.
Great.
Okay.
Thank you.
So we're a little bit ahead of time, and we're going to hear from somebody from Maine Acquired Brain Injury Advisory Council. So are Scott Mayo and Sarah Gaffney, are they? There's Sarah. Hello, welcome. Are we expecting Scott, or are we just too far ahead of time?
Nope, he's on. I think he's
Oh,
just
there he
working
is.
on getting his video and
Okay, I see his name.
he's gonna go first. So
Oh, okay. We got time. Welcome to the technical vagaries of the Zoom era.
yes, I'm just grateful it wasn't yesterday when all three of my kids were home. Nothing quite like a Zoom meeting with a 3-year-old.
I had my dog join me during this morning session, but I don't think anybody knew.
We had a statewide support group this morning that had many animal cameos. We welcome them.
I'm surprised we haven't heard from Aaron's cats yet. Scott, are you there? Okay, what I proposed, how about if we take a 10-minute stand up and move around break and come back? We still have time and we're actually ahead of schedule. So we'll reconvene at 2:43, and that'll give Scott hopefully time to
I'll shoot him a
recover.
quick email.
Okay, so we'll be back here at 2:43.
Hey, Scott, you might want to mute your voice right now.
Okay.
So before we proceed, I want to check with Representative Meyer. Do you have any other icons you can raise other than a hand that you don't have?
Let's see. I actually do not, Senator. I do not. I don't have any reactions along here or a raise hand function.
All right, just checking. All right, so it's 2:43, so we can resume this hearing of Health and Human Services. We're hearing from some of the statutory agencies. And next up are the folks from the Maine Acquired Brain Injury Advisory Council. And I understand, Scott, that you're to go first. Welcome.
Thank you very much. I apologize for missing my opportunity a few minutes ago, right before, I guess it was go time. Technology failed. So,
great excuse to have a stand-up break, which we don't do enough of.
Great. Well, thank you for having us this afternoon, Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. I'd like to take the opportunity today to tell you a little bit about the Acquired Brain Injury Advisory Council, a little bit of our history, a little bit about the work we did last year and what we're hoping to accomplish in 2021. Along with me today is Sarah Gaffney, who's the program coordinator with the Brain Injury Association of America Maine chapter, and she's going to speak about two specific issues after I'm done. Work related to an ACL grant and LD 297. So let me first start by defining acquired brain injury. First of all, about every 9 seconds, somebody in the United States sustains an acquired brain injury. And an acquired brain injury is a brain injury that's not congenital, not degenerative, doesn't happen during the birthing process. ABI is kind of an umbrella term for all traumatic or non-traumatic brain injuries. So your non-traumatic brain injuries would be someone that's had a stroke, someone that's had a brain tumor, or anoxic brain injuries where there's lack of oxygen to the brain. These brain injuries can affect individuals' physical function, their cognitive function, their emotional functioning, and combination of all of those things. In the US, we believe there's about 3.5 million children and adults that sustain an acquired brain injury every year. And in the state of Maine, we believe that number to be around 10,000 people. Roughly about 15% of those folks will need some type of long-term, lifelong support. Now, related to our history as a council, we were formed in 2002 to support a grant at that time, and then was established in statute in 2007 to provide oversight and some advice to the Department of Health and Human Services and the legislature. Every year we're bound by bylaws to meet at least 5 times. This past year we met 10 times, most of those virtually due to the pandemic. We are also bound to have 2 public forums where we solicit the public to provide any type of opinion, feedback on brain injury services. Over the last 14 years, we've had over 50 of those throughout the state of Maine, and actually one in New Hampshire at one time. So we're able to get out there and kind of hear from folks about what's working, what might not be working, what types of supports they might not be aware of, and we can kind of connect them. The services that the Office of Aging and Disability provides in the state of Maine related to brain injury services include 2 specialized nursing rehab facilities. They have a total of 44 beds dedicated to folks with acquired brain injury. We have a brain injury home and community waiver that as of the end of last year was serving 205 individuals. 45 folks had funded offers. And 100 of those individuals were on a 100 other individuals were on a wait list for those services. Currently, there are 26 Maine residents who are receiving brain injury services outside of the state of Maine because the state of Maine does not have services that meet their needs. So these folks are having to leave the state of Maine to solicit and receive services to meet their needs. We have 4 providers of care coordination, which is basically, basically a case management service within the waiver, and they serve anyone that's active on the waiver. So right now there's 205 folks receiving care coordination. There are 161 community residential beds and 2 in-home support programs. So folks living at home that need supports to drop in and help them with whatever their needs may be. There are 7 outpatient programs across the state. Last year, 491 individuals accessed those services. That's just folks that are on main care. Majority of those outpatient programs also receive folks that might have commercial insurance, that might be private pay, there might be some other means of payment outside of main care. So that number is actually significantly greater than 491. There's 1 work order day clubhouse in the state of Maine. Last year, they served 33 individuals. And there are 2 voc rehab providers who last year served 173 folks. Some of the things we worked on last year as a council was a little, what I call self-care. Sarah will talk a little bit about this ACL grant, and one of the items that we needed to address as a council was to look at our membership, and we brought our membership up to 50% representation for survivors and family members. So we're having an increase in the number of members, and more specifically, an increase in the percentage of voting members that are survivors and family members. With that, we needed to kind of design a new orientation program for new members so they understood exactly kind of how the council functions. We also worked on being in the public more outside of the public forums. We attended brain injury resource fairs and annual educational conferences, which helps us engage with the public a little bit more and gets our names out there and allows us to hear more about what's going on. In 2020, we were named the steering committee for the upcoming 2021 brain injury needs assessment, which we're looking forward to undertake this year and getting all that information out. I think the last one we did, Sarah, you can correct me if I'm wrong, that was 2016. So it's been 5 years since our last needs assessment. Another piece that we worked on last year is a long-standing item. It goes back to at least 2010, and that's looking at getting folks that receive acquired brain injury services, a list of rights. Right now, there are no rights of recipients for folks receiving brain injury services. We're working with Representative Hepler right now on having an emergency resolve submitted to study what it would take to get that to happen and to rule, and finally having some specific recommendations and have the brain injury world identified in these rights. So whether it be adding language to an existing statute or doing something completely separate. But that's something that the council has been working on, like I said, for a very, very long time. One of the other things that we worked on a lot last year was just advocating for resources and prevention initiatives around the opioid epidemic and the result of opioid overdoses that can result in an acquired brain injury when somebody overdoses that could impact their ability to have oxygen get to the brain. I don't think the general public's very aware of some of the residual effects after an overdose related to the brain. So, advocating for more awareness, looking at treatment options, just making it known to the public that there are services out there. And then also domestic violence, which years ago had been talked about as being one of the leading causes of traumatic brain injury, and also at the same time, probably one of the causes of traumatic brain injury that's most underreported. So really advocating for services around those two things. Something we needed to add to the list of other potential causes of acquired brain injury is the COVID-19 issue. Again, this is a respiratory disease. So folks that are dealing with severe respiratory issues as a result of the COVID virus are coming out and sometimes having issues related to cognition, endurance, things like that. So there's a whole other kind of other piece to the COVID world that we need to make people aware of and make sure that the medical world is seeing this, and that also individuals know that, those struggles might be related to that. Some of the things we'd like to work on for this coming year is obviously that rights piece, to finish and have that emergency group meet, get some information around what we can do with rights. We'd like DHHS and ODES to add licensed substance abuse counseling to our outpatient clinics. outside of what's going on with the opioid epidemic, substance use has been a major issue. A lot of times goes hand in hand with brain injury, traumatic brain injury. So those substance use counselors are very important to helping individuals getting outpatient services process what's going on with their use or abuse issues, on top of having the brain injury. So it's something we would love to see added into rule, so that Section 102 of rehab services could now have access to substance use counselors. We would like to see the department appoint a representative from the Office of Children and Family Services to our council. There's a lot of unknown out there with the kids in the schools and exactly how they're being diagnosed or not diagnosed with brain injury. There's a severe lack of services for children in this state for brain injury services. So we'd like to have some representation from the Office of Child and Family there. We'd like to seek some quarterly reporting from the department related to the number of individuals that are receiving services, what the utilization of those services are for those folks. Is there a waiting list for particular services? So more for us to kind of understand exactly what the snapshot of the state is every quarter, so that we can kind of design some recommendations, some advice around what's happening in the moment. Last year, we wanted to work with the Department of Education, but COVID really had a big kind of blockage to that. That was a big barrier. We really want to work on getting a survey out there to students, family members, and teachers related to the effectiveness of services for kids with brain injuries in our schools. So that's something we can hopefully work on this year. We do have a representative from the Department of Education on the council, and that's how we'll kind of work with them to get that done. Those 26 individuals that are receiving services out of state would really benefit from a neurobehavioral treatment center here in the state. Like I said, we currently can't meet their needs. We need to have some type of program in the state of Maine that would allow them to come back and get the services they need to keep them here. It's going to be more effective for their treatment. It's going to save the state dollars, whether it be in cheaper treatment delivery or the transportation costs that go into getting individuals out of the state is enormous. So there's savings in that. We'd like to work on the creation of an ABI trust fund to help support children, adults, and family member caregivers who are underserved or not served at all. A lot of times in this state, if you don't have main care, your commercial insurance, your Medicare has a very short term of, kind of coverage. So folks are oftentimes left leaving treatment before they really have maximized their full benefit. And lastly, what I'd like to leave you with is just some more thought about, what we're doing, what we need to do around the opioid piece, and now even the COVID-19. So that's kind of my few minutes. I'm going to let Sarah speak to the couple points she has, and then we'll open up for questions.
Thanks, Scott. So I'll try to be speedy. The council supported Maine's application for funding through the Administration for Community Living's Federal Traumatic Brain Injury Partnership Grant. And Maine received a 2-year grant in 2019, and then contracted with the Brain Injury Association of America's Maine chapter to complete those deliverables. The focus of this grant is primarily on the intersection of brain injury and substance use disorder. As Scott mentioned before, this is a huge issue, in particular Maine's opioid crisis. Some of the accomplishments under this grant include a webinar on the intersection of brain injury and substance use disorder, a forum connecting the Maine mental health, substance use disorder, and brain injury communities, 4 sessions dedicated to the intersection of brain injury and substance use disorder at the annual conference, outreach and education to Maine substance use disorder providers, expansion of the membership of the Acquired Brain Injury Advisory Council to include additional advocates, survivors, and family members, and the establishment of a statewide virtual brain injury support group that will remain virtual after geographically based in-person meetings resume. In addition, the council supported the passage of LD 297, which is an act to strengthen brain injury resources for underserved populations, which was signed into law in June 2019. Maine's Department of Health and Human Services has since contracted with BIA Maine to provide core state brain injury supports. Under this contract, BIA Maine has produced the 5th edition of the Maine Brain Injury and Stroke Resource Directory, electronic and hard copies of which are provided free of charge to anyone who would like them. Held the 2020 Maine Brain Injury Resource Fair in Augusta. Held the 11th Annual Conference on Defining Moments in Brain Injury in October 2020. Built a robust resource facilitation team, which received 808 contacts in 2020 and includes neuro resource facilitation, which is longer term one-on-one support to help survivors and families navigate the system. These services are also provided completely free of charge. Provided support for the network of Maine brain injury support groups, which engaged more than 2,000 participants in 2020. And provided education for Maine hospitals, providers, and community organizations, as well as collaborated to establish a statewide virtual brain injury caregiver support group. Caregiver supports are pretty lacking in the state of Maine. And so that group is actually starting next month. The Council and BIA Maine are proud of these accomplishments and the impact that they've had on the Maine brain injury community. And thank you for your time. Sorry, I was trying to be speedy.
Thank you. So, and thank you, Scott, too, for sharing this information. I see a question from Representative Craven.
Thank you, Mr. Chair. Thank you both, especially I learned a lot. Things that I hadn't thought about, you know, for example, people using opioids or you know, having overdose issues and then ending up having a brain injury. I hadn't really thought about that, but I would like to know where people, which state people are being sent to. You know, are they all together where families can hire a van and go visit, or, you know, are they all over different states, or how's that working?
I think they're all over. I think we have, oops, can you guys hear me? I know Florida takes a lot of people. I believe there are some around the Ohio area and things like that. Derek Fales, who's the brain injury manager with ODES, can probably get more detail on exactly where everybody is. It is my understanding that when these folks do leave the state, it's Maine Care dollars that are providing the transportation for the individual to get there. It would be my belief that if families are engaged in any way, that it's their responsibility, you know, on how they get there and how they might support their loved one while getting treatment out of state.
Maybe we can get Anna and Aaron to pass that question along to Molly and getting accounting for those 27 people and what it costs the state. Yes, Representative Zager, you had a question.
Thank you, Mr. Chair. Thank you very much, Mr. Mayor and Ms. Gaffney. Regarding the lack of neurobehavioral treatment program in Maine, I was wondering if you could tell us what is the highest level of care that we do have. You know, what is the increment that we have? You know, the delta, you know, the gap of between what we have and what we are referring to other states for. My understanding is that Bayside provides some of these services, and but clearly not enough. You know, there's not enough in-state resources. So could you illuminate that, please?
Yeah, probably the best way to look at it is through our home and community waiver. And there are 3 levels of residential support. Level 2 and level 3 are both designed for folks that need 24/7 care. Both levels are deemed probably unsafe for whatever reason to be alone overnight, especially. So they're both called neurobehavioral level of care. So individuals that are level 3 are usually the most involved. And what's supposed to happen within the waiver is that a home provider this individual is deemed probably not appropriate to go into the community to seek services related to their brain injury. It just wouldn't be the right setting for them or the other individuals that are at that care setting. So the home provider would work on bringing in resources to the home to serve that individual. Sometimes there are individuals that are just, they're not really appropriate even for that level. So it's it's like we need another level before they can get to that level 3. We've always thought of a program that would be designed to maybe have someone over a course of 12 months attend this neurobehavioral treatment center, get intense neurobehavioral treatment, and then the next stepping stone for them would be that level 3. A lot of times these individuals are maybe aggressive towards staff or other housemates, and it's not manageable in that community setting. So they need just kind of a higher level of kind of more almost institutional care for a little while before they get put into a home and community program, if that helps.
So these are there is a segment of care that has a finite period of time that might make it so that these folks could then return to care here.
Yeah, that would be that's the goal, right? Is to get them, whether they're out of state right now, is to get them to a point where they could come back to Maine and possibly be served within the service system we already have. Or the goal would be to not even have those folks have to leave the state. So if there were some type of program that matched what's going on in Florida, matched what's going on in the other states, these folks wouldn't have to leave the state. You know, and I'm a provider. I'm a big believer in getting caregiver and family members involved in the treatment. It's just going to help be that much more effective. You've got education going on both sides. The family members, you know, when this person comes home from the state, may not have been engaged deeply with, okay, now what do I do? Where if you have that system in the state of Maine, it becomes a lot more feasible to provide that.
Have you requested a study group be convened to put together some outlines to what this would entail and would cost?
We've looked at that, and there's actually some material I think that was submitted to this committee last year through Derek Fales. I can try to access that and get it to you. The program itself, there are models out there that Maine could mimic and implement.
Mm-hmm.
So that would be the goal, is to kind of look into, you know, I think one of the barriers we ran into in the past is actually, you know, what are the costs? What are the provider-driven issues to get into this line of business and serve folks? So those are some of the issues I think we still need to work on.
Okay. Thank you. Representative Connor?
Yes, thank you, Mr. Chair. Thank you, Mr. Mayo, Ms. Gaffney. I appreciate the briefing. And I echo my colleague and fellow Lewistonian, Representative Craven, that I did learn quite a bit today, so I appreciate it. My question, and forgive me if you mentioned at the beginning of the briefing and my memory just lapses, but what is an estimated total number of Mainers that are dealing with brain injury? And then what do you see that number elevating to? Related to, as you stated, you know, SUD, domestic abuse, and COVID.
You want to go ahead, Sarah?
No, I was just going to say I don't know that we have good numbers at this point from the CDC. That's always kind of a challenge. That said, you know, I think the increase with the opioid epidemic. So part of that is, you know, someone overdoses and they have a lack of oxygen to their brain, and then there's potentially a brain injury there. And then if they overdose again, you know, brain injuries compound. And so we're saving so many more people now with our more extensive efforts against the opioid epidemic, but we're ending up with these individuals who we don't know the numbers. Their brain injuries aren't even getting recognized. And so a big part of what we've been doing, certainly under the grant, has been just raising awareness about that, talking to the substance use disorder providers, talking to the public, you know, just like you mentioned, you know, learning that it's like a light bulb goes off. It makes perfect sense once you're presented with the information, but it's not well known. So those numbers, we absolutely don't have good ones for. And the same thing with COVID-19. It's very multifaceted and it's all still very new. I know there have been a few reports and studies that are showing, you know, brain damage as a result, whether it's due to intubation or younger people having strokes, all sorts of different potential impacts, but it's just a little early to know really what the extent of that impact is going to be.
Excellent. Thank you. That's all I had, Mr. Chair.
Thank you. Representative Stover.
Yes, I wanted to address the domestic violence issues related to brain injury and encourage you to look back. I'm sure in archives somewhere, there was Dr. Beth Pearson from Dartmouth had done a study with the Maine Coalition to End Domestic Violence. And even though the study was done quite a few years ago, the data isn't going to look that different. And it did have some numbers in there based on, you know, sort of percentages of what we know about domestic violence and then what we know about victims of domestic violence who sustain head injuries and repeated head injuries. So it's a very good study. It had 100 individuals, different individual women from across the state of Maine. And I would encourage you to look at that because I think it's been a great platform that's never really been launched. So thank you.
Can I add a quick thing related to that?
Sure.
So I just recently participated in a webinar that was specifically on brain injury and domestic violence, and they had some really staggering numbers. They're not Maine specific, but I'd be happy to kind of dig back through that and provide that for the committee if that would be helpful information to just kind of get a picture of what those numbers and what that impact is.
Sure. I mean, I'm always interested, so sure.
Thank you. I'll see what I can get.
I think another thing we can use, Representative Connor, is to look, I think nationally, they're saying somewhere between 2 to 4% of the general US population has experienced some type of ABI. So I think you can kind of associate that to the US population. That would include, you know, traumatic brain injury and stroke and things like that. And just another quick one, in the criminal justice system, we had a presentation just maybe 3 or 4 years ago where they spoke to maybe up to 85, 90% of inmates have probably sustained a brain injury before they got in prison or possibly sustained one while in prison. So that's a whole other kind of group that has been overlooked for a long time.
Thank you. So I think that'll conclude this portion. I appreciate you being here, Mr. Mayo, and Ms. Gadney. Thank you for your contribution, and we'll look forward to that other piece of information that's coming. So thank you and enjoy the rest of your day. That brings us to the Maine Children's Trust, and I don't see anybody from them who's joined in. Yep, there we are. Hello.
Dr. Claxton.
Welcome.
Thank you for having us. Pam has joined us and Heidi should join us. Heidi. So thanks for having us. I know you've had a long day already. And so Senator Claxton, Representative Meyer, members of the committee, Representative Craven and Senator Moore, if she gets back, there she is, as you know, are members of the board of the Maine Children's Trust. And I have the honor of being the volunteer chair of the board and have been involved with the Children's Trust for quite a while. It's great to see everybody, and to the new members of the committee, welcome. You have a great committee to work on, and Representative Connor, I see you on another committee as well. And for Representative Perry, that's a summer background and not a winter background. I bet it doesn't look like that in Calais today.
It's wishful thinking.
Yeah. So as you guys know, the Children's Trust is a nonprofit that was created actually as a state agency back in 1985. We were converted to a full nonprofit after that in 1994, I believe. And we are still a creature of statute as a result. So our board is made up not only of your colleagues in the legislature, but private members, providers who do frontline service, trying to prevent child abuse in Maine. And so as well as a couple members from the department. So we have a fairly diverse and unique board. It sometimes makes it a challenge, but it's a wonderful board and currently a very engaged board. We have multiple programs that we work with because our charge is really to help coordinate efforts throughout the state to prevent child abuse. I'll let Pam and Heidi talk about the main ones, but the main ones are Maine Families and the what we call the CAN councils. And both of them have been strengthened recently, and we've had a lot of work. But we are clearly, as you know, in a really challenging time. As the pandemic brought to an abrupt end, are visiting families and interacting personally with families. So that made that a challenge, but we were able to transition quickly to providing as best we could through our agencies, contact through phone, video, Zoom, everything else to reach families so we can keep that touch point, which is so important to keeping that family engaged so that we can give them the best help possible to make their children thrive and so on in very challenging circumstances that most of them are engaged in. So I think that's about it for my little rough outline. I'll turn it over to Pam and Heidi to give you a more in-depth view of what we do.
Thank you, Charlie. Good afternoon, everyone. As Charlie said, our role is to provide leadership and coordination of efforts throughout Maine to prevent child abuse and neglect before it occurs. The Trust provides funding and support for prevention programming, as well as coordinates several statewide collaborative initiatives to strengthen families. We don't do any direct service work, but we do provide central coordination for 2 statewide prevention programs, Maine Families Home Visiting and the prevention councils that are located in every county in the state. Through contracts with the Department of Health and Human Services, we're responsible for providing the oversight of and the system supports for both of these programs. That includes technical assistance, training, quality assurance and improvement, data collection, and reporting. The Trust also convenes the statewide Safe Sleep and Abusive Head Trauma Prevention Coalition and supports community training and materials costs related to that work. In this past year, in the midst of the pandemic, we launched a statewide messaging campaign called In It Together Maine to provide supports to help parents navigate parenting during this particularly stressful time by connecting them with local parenting resources such as the prevention councils provide. Beyond the span of the pandemic, the campaign aims to make a lasting effect in the way that families in Maine consider the resources available to them and to cultivate communities of parents that stay in touch and support each other long after the retreat of the virus, which I hope we all see soon. Our newest initiative that you'll be hearing more about soon is called the Front Porch Project. Front Porch is a community-based primary prevention initiative based on the belief that everybody can and should become more aware of how to help protect children and support families in their own communities. After the tragic deaths that occurred 3 years ago, we heard many people ask what they could have done. Front Porch provides community members with the knowledge, skills, and encouragement they need to take an active role in preventing abuse and neglect. The prevention councils will be offering Front Porch training workshops in their local communities. And you should know that Front Porch is being funded in part by funds that were donated to the Trust in Marissa Kennedy's memory. I'm going to provide a quick overview of the Maine Families Home Visiting Program and then let Heidi Akure, our prevention coordinator, tell you a little bit about the councils. Maine Families Home Visiting is a home-based parenting education and support program delivered through a network of local agencies. This evidence-based program works with expectant families and families with new babies to promote safe home environments, healthy growth and development for babies and toddlers, and to provide key connections to needed services. The program typically serves about 2,000 families a year, although it was a little lower this year due to the pandemic. Most participating families are facing challenges in their lives that can impact their children's well-being. Our focus is on the family, understanding that children's most important relationships are with their caregivers. As such, beyond parenting and child development and health, we also focus on parents' needs and challenges and work with them toward achieving their goals for their children and themselves. Maine Children's Trust has supported home visiting in Maine since the 1990s through advocacy, grants, and training. In 2010, the Trust assumed responsibility for providing system coordination, quality assurance, and technical assistance with all the state contracted home visiting sites. In 2016, the department consolidated all the home visiting contracts and the system supports into one master contract with the Trust. The Trust also became home of the Parents as Teachers State Office, which is the national model utilized by the program. The program was recently put out to bid this past year, and Maine Children's Trust will continue in this role going forward. The Trust has managed the direct service contracts with the local agencies since 2016 with no additional cost to the grant beyond the infrastructure cost. So I'm going to stop there and let Heidi tell you a little bit about the council's work, and then we'd be happy to take questions.
Good afternoon. Can you guys hear me okay? Since 2015, DHHS has executed agreements with the Trust to expand, lead, and coordinate a statewide project to prevent child abuse and neglect. Through this effort, the Trust supports the prevention councils in their statutory role as the county-level coordinating entity to lead and deliver child abuse prevention efforts. The Prevention Council statute guides the Trust in providing central statewide leadership, strengthening the network, and ensuring ongoing delivery of free evidence-based and evidence-informed child abuse prevention programming in every county in Maine, mentioned earlier. The Trust provides a centralized data system, core programming training, and technical assistance to ensure consistency in service delivery as well as model fidelity. The Prevention Councils use child maltreatment data provided by the Office of Child and Family Services, a needs assessment which analyzes gaps, community input, and an advisory board to select approved evidence-based parenting education supports and strategies. These targeted and individualized prevention plans focus on programs and activities that will lead to the most substantial advancements in preventing child abuse in each county. In the first quarter of this fiscal year, Prevention Councils provided Circle of Parents groups and play groups, as well as support groups to over 600 people. In parenting education, 289 people participated in multi-session evidence-based curriculums. The Prevention Councils also serve special populations identified through prevention planning and offer programming for fathers, substance-affected families, co-parenting separated families, prenatal families, as well as offering education in child sexual abuse prevention. The councils also provide training to family-serving professionals in every county in the following trainings: infant safe sleep, protective factors, period of purple crying, which is an abusive head trauma prevention training, and mandated reporter training. And during the first quarter, Prevention Councils provided training to 679 participants in mandated reporter training, and it's where they did note that 526 of those were educators. Leave it at that, and I guess we'll turn it over for any questions you might have.
Thank you for bringing this information to us, and I will see if there's anybody in the committee who would like to ask some questions. I don't see any. What's the best way to get some printed material or some electronic material that we could review?
We have our annual report coming soon, and that will be transmitted to your committee and the governor's office when it is off the press.
Very good. That'll be great.
Senator, it looks like Representative Craven and Senator Moore have questions.
I can see that. Senator Moore.
I just really have a comment. I guess since this whole pandemic, everybody's hair has grown since I've seen you. It's a whole new look for you guys. That was.
You're right. We all have COVID here.
Yep. It's the same color though.
Representative Craven.
Yeah, thank you, Mr. Chair. I didn't have a question either. I just wanted to say thank you for the report, and it was nice to see all of you.
Thanks. I did, as we were talking, Representative Craven and Senator Moore, that I probably need to get the presiding officers to reappoint you to the board and stuff. Since the new legislature's been seated, I mean, it's a formality and we're not letting you go, so.
Well, very good. There being any other questions? Then we'll thank the three of you for joining us and sharing that information. We'll look forward to that formalized report or the annual report and take it from there. But thank you for all your work over the years. Important.
Thank you, Senator. Take care.
You too. Oh, Senator Moore's waving at me. No, she's not waving at me. All right.
I was just saying goodbye to them.
Oh, okay. So long. Thank you. All right. So according to my schedule, we've completed going through the statutory bodies that we were scheduled for this afternoon. Anna, did you want to jump in here, or Aaron?
You actually have one more, and you should be able to see Katie and Stash on your screen. It's the HIV Advisory Committee.
Oh, it's on the second page. My bad. Okay, I had to flip it over. All right. Sorry, I misspoke. Chair is in error. So I'd like to welcome Stash Bailey and Kate Rutherford from the HIV Advisory Council. I'm sorry that was unintentional.
Not to worry. Well, thank you all for making this happen this afternoon. There are a lot of things happening out there in the world that obviously make these kinds of meetings a little bit more difficult, but obviously it's really important to you all, and it's important to us for you to get an idea of who we are and what we do. If I may, I'd like to have Katie Rutherford, who's the Executive Director of Franny Peabody here in Portland, as well as an executive member of HIVAC, sort of begin with an overview, if that works for you, Katie.
Hi, everybody. Thanks for having us and taking the time to reacquaint yourselves with HIVAC. We are commissioned under Maine statute, so it's HIVAC's membership is quite diverse. It's made up of members of the community who are HIV positive, a number of social service providers, such as Franny Peabody Center around the state, in addition to medical providers, infectious disease providers in particular, as well as members of the Department of Correction, Department of Education, the Maine CDC, the Office of Maine Care Services. And we meet monthly to sort of review what everyone is going through, the challenges that people are facing, and try to, sorry, I should have mentioned that membership also includes obviously members of the legislature. And we meet to kind of problem solve together, propose legislation, and also kind of get a handle on what we're going to advocate together for as a group. It's a wonderful opportunity. I think a lot of the members don't always get into the room with all of the individuals that represent each of those agencies and structures in terms of the impact that those systems have on HIV and AIDS and service providers. So it's a really important group, and we are charged with making recommendations to the Office of the Governor and obviously providing you all with a report. We do have the 2019 report that hopefully you received ahead of time. There's a lot of information in there. Currently, the 2020 report is being developed. Obviously, it's going to focus heavily on the impact of COVID-19 on the HIV affected community. And of course, we're very grateful to you all and to the state of Maine in general in terms of how we've been able to continue services amidst the COVID-19 pandemic for people affected by HIV, particularly as this has brought up a lot of feelings that were similar to the beginning of the HIV/AIDS epidemic in the early 80s. So COVID-19 has had particular impact on the individuals that we serve, and being able to have telehealth allowed through these services so that we can provide uninterrupted care has been pretty critical to individuals living with HIV in the state of Maine, as well as the allowances under Maine Care for things like physical signatures when people don't have access to transportation, and obviously their immune systems are compromised. Those flexibilities that have been offered through the state of Maine have been really critical to keeping people engaged in care. So that's sort of a summary of what HIVAC is. I'm going to let Stosh kind of continue on with some of the things that the group engages with.
Thank you, Katie. Yeah, just to give you an idea of what HIVAC's been up to for the last 2 or 3 years. I myself have been involved with HIVAC since 2016. And with the hard work of all of the different stakeholders at the table, we've managed over the last couple of years to sort of reconfigure and reprioritize perhaps the frequency and the volume of who's in the room, so that we're not only just simply bringing together people who are well-versed in EPI reports and the funding and the administration of those funds, but we're also putting agency in the hands of HIV-positive people who live here in Maine. And I've got to say that over the last couple of years, that has really paid off in high dividends. I understand that it's hard to gauge where HIVAC is in terms of where it's at in terms of the mind of legislators right now, and maybe even the public, simply because we have so many other important things that we need to consider with COVID. But I'd like to just reinforce something that Katie just brought up, which is, there's a lot of things that are very similar to HIV in the mid-'80s, and some of the things that we're seeing in the tea leaves with COVID, and the things that will undoubtedly unfold over time. I think that it's fair to say that if you know anybody who may have contracted COVID or gotten ill or something of that nature, it's not comfortable to talk about. There's a certain amount of stigma, depending upon where you live, that's obviously rolled up and folded into that. And I say that because that's primarily, I believe, what HIV/AIDS is up against in this country, first and foremost, other than, of course, the mechanics. And I'm going to just bring it back around to this idea of giving those that live with HIV in Maine agency through this organization, because that in and of itself puts those who live with it on a granular level at the forefront and almost the advanced guard, if you will. So this particular organization has been able to essentially distill itself into not only an organization that advises you all, or we don't advise you, but we advise you as to what we see, and we give recommendations based upon the unified voice in the room. But it also it's been giving us a great opportunity to reevaluate where we've come as a state and where we need to continue to go. And perhaps moving forward, as Katie mentioned, we're gonna sort of we're gonna look through all of the implications of COVID as it relates to the last calendar year, in terms of infection, et cetera, so on. And we're gonna re-immerse ourselves in maybe what it looks like moving forward with you all, so that we can plan for what the future looks like as people with HIV live longer and more productive lives. Their needs and our public health needs change. And so I think considering where we're at in the world, this is a great opportunity to re-engage in that reimagination, if you will. And so, if I could quickly just thank the numerous members of the joint chambers who have been involved in this organization. They've really helped give us a voice over the last few years. This past December for World AIDS Day, we, in a very meaningful way, engaged the governor's office and obviously the CDC, who we work closely with, in order to bring to bear, just what it is we're dealing with, and honoring those who have lost their lives here in Maine to HIV/AIDS, but also to consider how important it is to recognize those that have survived, the family members, et cetera. So with that, I want to extend that gratitude to you all. And we look forward to perhaps having, it's not necessarily going to be a lobby day because lobby has so many connotations, but we just want to re-engage with you and maybe let you all get an opportunity to ask us questions back when the legislature's back in session in a more, in a normal way, I guess you could say. So, yeah, thank you all.
Well, thank you for joining us.
Yes.
Are there particular questions of the folks and their perspective that you want to follow up on? Representative Craven, you usually have something that you'd like to contribute. Go ahead.
Thank you, Mr. Chair. So I'd really like to know if the incidence of HIV are increasing in Maine or has, any kind of change in the numbers, either way, increasing or decreasing?
Sure. I'll give you a general sense, and then certainly, Katie, please chime in. I do know this, that Maine is one of the lowest incident states in the country. And again, because of surveillance this past year, we don't have a firm number necessarily on where we're at, not to mention it's very difficult for people to get tested right now. Aside from some of the programs that have been launched by entities like Franny Peabody, which are making it possible to get home tests sent to you. But I can say over the last 4 years that we have either been steady or dropping in terms of incidents. We do have some really specific things to this that are unique to the state that help in that. With HHS, we have a special benefit waiver through MaineCare, which is one of a kind. There are obviously some needs I see moving forward in terms of representation for AIDS service organizations throughout the state geographically, so that people can obviously find the things that they need in order to keep these incident rates low. But I'd say that we're really blessed with the team that we've had in place for a number of years. Katie, is there anything you'd like to add?
Yeah, I'll just say the state of Maine over the past 8 years or so has had anywhere between like 35 and 50 new cases annually, just to give you a sense of what that low incidence rate looks like. So because the numbers are so low, that type of gap can seem like a pretty large, pretty substantial percentage, either up or down. So we're really kind of on the cusp of getting to a point where we are eliminating the epidemic in Maine in terms of new infections, but it also puts us at a really fragile perspective in terms of catching people who go undiagnosed. And particularly, as Stash mentioned, during the COVID epidemic, we annually perform around 600 HIV tests as just Franny Peabody Center. Those numbers have gone down even with the addition of home test kits that we've been able to distribute for free, thanks to the Maine CDC and some other emergency funders within COVID. We've seen those numbers drop from about 40 tests a month to 3 to 6 tests per month. So, and especially with the opioid epidemic growing in Maine, especially amidst COVID, people are just not accessing the testing services as they have been in the past. That's something we're really trying to keep an eye on in terms of getting awareness out about the availability of home test kits, but also just the importance of prevention services in general.
Thank you. I have a follow-up actually. St. Mary's had a case management and referral service, and I think it was last year, we got several concerns from people that it was going to be reconfigured, and I wondered if you have any information about that, and if there's any cause for any concern for people.
I'd be happy to answer that. So Franny Peabody Center actually administers the Ryan White Part B case management program, which is a statewide program. Comes from the federal government down to the state of Maine, and then we administer the case management side of it. Because we're the statewide provider, we subcontract with St. Mary's for those individuals that are eligible for the Ryan White Part B program. Basically, that eligibility follows individuals who aren't eligible for Maine care due to immigration status or being over income. So we do work with St. Mary's directly on a portion of those case management clients. So when that concern came up, we were immediately notified. And we've been working with St. Mary's to look at possible solutions where we as Franny Peabody Center may be able to support St. Mary's in preserving those case management services there, because obviously clients have a very close connection to their provider there. We work really closely with the case manager there. So we've been doing everything we can to support St. Mary's in continuing those services. At this moment in time right now, we've kind of proposed a possible, I don't want to say solution, but just a sort of a mode of assistance. And we're waiting to hear back from them. But I think there was sort of a little bit of a backtrack in that decision that you probably heard about at first, where they were going to be shutting down the HIV case management program, or at least trying to transition those individuals to, I think the title is like care manager, and I think some of the justified concern around that proposed shift originally was around eligibility. Can get so complicated for people living with HIV because it's much different. Eligibility for Maine care, whether it's through the HIV waiver that Stosh mentioned, or eligibility for federally funded housing programs through our statewide program that we administer from HUD, which is Housing Opportunities for Persons with HIV and AIDS, or again, that Ryan White program. It's not, they're very intricate systems that are very specific to HIV and really don't translate to channels that other agencies are used to when it comes to general eligibility for Maine care. So we tried to really advocate for that program to be preserved because of the intricacies and the special eligibility pathways. So it's looking better right now, I guess is the short answer for you.
Does that answer your question, Representative Craven?
Yes, thank you. I've actually talked to somebody at St. Mary's, and they sounded committed to keeping the program, so I was a little bit relieved. That's what I told my constituents, but I haven't heard anything for a few months, but thanks.
Okay, thank you. So that'll conclude our hearing from the statutory agencies. At this point, we're scheduled to move into a work session. I will see what the leads think about a caucus break now or after we hear the amendments. Do you have a preference?
Well, I would think probably to hear the amendments first would be good, just so we have an understanding of what's being requested.
Sure. Okay, so we'll proceed to that. Anna and Aaron, do you want to jump in here, or what's the next step?
Sure. Do you want us to explain them one at a time? Is that what you would like?
Oh, I can start by introducing the one. I don't have all of my notes with me, but I have some. And as we
also have
mentioned,
the language to share whenever you like.
what is it?
We have the language to share whenever you like.
Sure, if you want to put that up. So this is a one pager that came from the folks at Maxby about supporting the community of providers, direct care providers for the intellectually developmental disabled community, and their proposal to increase support short-term for 25%, and then also to do some changes to the retainer payments. That's the issue that was brought up at our last work session. And I told you some more final language would appear. So we have the final language. I think we also have some financial modeling that came out today that you probably haven't had a chance to look to. Am I right about that, Anna?
No, I think Luke has added it on, and if Aaron scrolls down, and Luke can explain it.
Okay. All right. So are we in a position to talk about the financial implications of this amendment? And there is another amendment coming related to the mental health, behavioral health community. So let's stick with this one right now, which is focused on the folks providing home and community-based services. And I saw Luke was here. Have you done the crunch work to give us an idea of what the costs might be for this?
Sure. So I should note that most of the crunch work, as you described it, was done by the department. We actually sent them information on Monday afternoon, and they were able to get us back some information, which was very helpful because there was a bit of a minor change to the language that you see here. The original proposal by Maxby included all the rates in section 21 and 29, 18 and 20. But there were 4 specific rates that had an increase in the supplemental budget last year. And those increases were greater than 25%. So it was suggested to just remove those 4 rates. Once that was the case, I needed some help because I did not have the data code by code. So that's where the department was able to pull the most recent information for all the codes, and we were able to remove those 4 codes. So the information you have in front of you is a little different in total than what you saw when Maxby presented their original proposal.
Mm-hmm.
And this does also include an estimate of what the increase would be for the retainer payments. So if Aaron would just scroll down to the bottom of this page.
So it sounds like we should thank Mr. Mann for getting this stuff done. So thank you.
Yes.
He's having trouble getting it to go up, Luke.
Okay. Maybe stop share, Aaron, and I'll go ahead and give it a try.
Sorry, Luke, I don't know what's happening.
This is some of the fun technical stuff we're all getting so very used to. There we go. Just want to make sure I'm opening the right file. Okay, so does everyone see now?
Yes.
Okay. So you'll note the way this is broken up, there are different blippies, as we call them, the initiative text, for the two different pieces. There's one that says provides one-time appropriations to temporarily increase certain rates. The certain rates that are described in the appropriation and allocation are what you see in the section A1 at the top. So there are many different program codes that are included in this. So it's broken up quite a bit. You'll see there's a developmental services waiver, Z211, and then this is developmental services waiver supports, Z212. And I'll scroll right to the bottom so we can see this is the total impact of the two initiatives. So the total general fund impact of both doing the 25% temporary rate increase for 4 months, January through April, and doing the retainer payment for 3 months is a general fund impact of 9.9 million with a total impact of 41.1 million. So that's the basic information on the payments. I guess I'll just see if there are any questions about that explanation.
I don't see any questions yet. One of the disadvantages to the current system is that I have no idea who's in the, so we do know that Laura Cordes was in the waiting room and has joined us as a participant. Are there any, yes, Representative Craven.
Thank you, Mr. Chair. Does the 41 million include the federal?
Yes.
Or is that also?
Yes,
Oh,
the 41
okay.
million is the total. The 9.9 million is the general fund.
Okay, thank you.
Are there any other questions about those monies? Okay. So my proposal would be to hear from Laura Cordes specifically and succinctly, and then we can see if there's any questions of her as to the origin of this and the why. So if you'd like to join us, Ms. Cordes.
Thank you, Senator. Good afternoon, members of the committee. It's nice to be back with you again. I will certainly keep it brief. I believe everybody, I was with everybody last week when we talked about this as a concept. My thanks to Anna and Luke and the department. I had not seen the fiscal note yet, and it is happily even less than what we had originally anticipated. I think most folks on this committee are certainly familiar with the outdated rates that providers serving adults with intellectual and developmental disabilities have contended with. And there certainly is some hope and promise next year and down the road long term as the governor and the department look to update rates. This amendment is really about right now here in this emergency with the immediate need to help get providers, the direct support professionals, those who remain on the front line and the caring for some of the most vulnerable folks in high-risk settings in the state to the other side of the pandemic. I have shared with you testimony you heard from other folks about our numbers just dwindling. We've lost 16% of our workforce by the end of the year. And the truth of the matter is people just aren't coming in the door anymore. We've been asked by the department in licensing to have, emergency plans, emergency staffing plans. It was even suggested to us in the fall that we look to give people hazard pay and incentive pay, but we are just not in the position to do that as a sector statewide without additional federal or state support. And in fact, in our emergency staffing plans right now, as we are the safety net for thousands of folks in Maine, our emergency for a lot of our providers, those plans involve the staff and board member taking someone home in case of more outbreaks for staff that affect our levels of care. that's not a staffing plan. We need to do better. So this amendment does those two things. It gets us a short term, just 4 months, not even through that fiscal year, just 4 months of added temporary rate increases so we can give folks the hazard pay, incentive pay they need to stay on the front lines, and then 3 months retainer payments. And this is estimated at just for the 3 months that programs have been closed because of the pandemic and following department guidance. That is just 15% of a month's support for community supports programs. And what I mean by that is these programs, they're medically necessary. Folks will need to access them, but if providers can't, keep the lights on, keep the rents, keep programs in place, they won't be there for folks who need and deserve them on the other side. Certainly having, this is a large workforce, main economic driver in many communities throughout our state. Getting folks an increase certainly during this very difficult time and during the surge in the winter means keeping relationships with folks on the in our care. DSPs build relationships with folks that are not only valued but really vital for folks' well-being. But it really keeps people in this workforce. It's already fragile. We can't have it break down further. And it keeps folks not only in the workforce, but puts dollars right back into Maine's local communities. Thank you. I'm happy to answer any questions you might have.
So do folks have any questions for us? Representative Meyer, you have your hand back.
I do have my hand back. Thank you. Thank you, Ms. Cordes. On the department's, the fact sheet that was sent to us, there was something referencing rapid staffing assistance, which is nothing I'm familiar with, and I'm wondering if you could elaborate on that.
I did see that fact sheet, and again, I'll take a moment to say I do appreciate the staffing levels, the telehealth and virtual supports that the department has provided. But that program in particular that you're referencing does not apply to Section 21 and 29 services. In fact, licensing has a memo for long-term care facilities, and they reference, reaching out to, home health care services. Home health care services don't employ DSPs, those programs, and I was surprised to see that because I think I would know about it if our members were using it. And as a matter of fact, the department itself has been checking in with IDD providers about those emergency staffing plans that I just described to you, where some members are saying, here's our plan, we would take this person home, and have not said, oh, well, here's a program we can provide staffing for you. So I believe that's probably for long-term care facilities or nursing homes, not for us.
If I could just provide some context. We have, that is a brand new program and resources we intend to deploy to congregate care organizations, facilities, including group homes. So they would be eligible for that. To Laura's point, though, this is a brand new contract and we have not deployed that staff, but to the extent that a facility is experiencing a staffing crisis, the state has mobilized resources to deploy it to make sure that the residents of that facility would be safely cared for.
Can you speak, Mr. Mann, to the cost of having a SWAT team available as opposed to maintaining people with the current staff? Are these people being paid more than $11.75 an hour or $25 an hour?
They're being paid more than that. We had to make sure they are also intended. We're not scaling it to the resource type in particular. So the nursing resources that we are mobilizing would be able to be deployed to a nursing facility or a group home or a private non-medical institution. So they would have the sufficient credentials to provide staffing support in any of those different types of environments.
Sure. So for a one-for-one exchange, though, they're likely to be more expensive than some of the direct care providers per hour.
More than, yes. I mean, the state put in place this contract, so it would be at no cost to the facility that's receiving the staffing support.
And I was just talking about the general fund, though. It'd be a bigger hit per person to the general fund.
I mean, I guess you could look at it like that. I mean, it would be, there's a couple different levels of resources, but they would likely be higher cost than DSPs.
Okay, yes, thank you. Thank you. Representative Craven?
Thank you, Mr. Chair. So where are you recruiting those people from?
We hired a staffing agency. There's most of them are from, I believe some of them are still being recruited. Most of them are from out of state. Some, I believe one or two was from in-state. But facilities, nursing facilities, or others are, have been relying on staffing agencies, both in-state and national staffing agencies, to make sure that the staffing ratios are maintained when there is an outbreak of COVID-19 in a facility.
Yeah, I know. I've been talking to the nursing homes about it, and they're in crisis. And for one thing, paying way more for agency staff, but also really having trouble literally sourcing them.
I mean, that's one reason why we decided to put this in place. One of the reasons is it is more expensive to do the short-term placements for a facility, but looking statewide, we can guarantee longer terms of employment because they can move from facility to facility, and it wouldn't be facility specific, and we can help cover some, drive down the price point of that. So there's some efficiencies there.
And it gives you some flexibility. Are there other questions of the financial implications of this? Okay, so that obviously raised the question, as it has multiple times in the past, about what we do to the fact that by steering rates or changing rates, we encourage people to move from one area of employment to another, even if it's totally unintentional, as has happened before in child and adult protective. So that raised the issue of whether we ought to be doing the same kind of thing for the mental health, behavioral health community. And that's what led us to the other amendment. And who would like to speak to that one? Representative Madigan has her hand up. Thank you. Virtual and physical.
Thank you, Senator Claxton. Yes, the need for the previous amendment led me to think that we needed to address some of the inequities that I see happening in the behavioral health field. And so that amendment, Anna worked on that, and you all should have a copy of that. I want to be clear that this is tailored towards those adult and children that have already been authorized for services at a higher level of care than outpatient care. For adults, they're adults that are Section 17 eligible, so they have a serious and persistent mental illness, and they're authorized through the contractor KEPRO to get services in their community. DLS services, which stands for daily living supports, is very analogous to the services that we discussed in the previous amendment, as far as they help people function and stay in their own homes. And this is designed to make sure that people don't be rehospitalized or decompensate in any way. In addition, the services for children, these are already children that have an identified DSM psychiatric kind of diagnosis, and they already have not been successful in outpatient care. And these types of services help them stay out of the hospital or stay out of residential care. And so these are, that's what these services are targeted towards. And they're very similar to the services provided in the previous amendment. In addition, these services, particularly DLS services in particular, there's a number of agencies that have stopped providing them because the rate does not allow them to adequately pay their staff and just break even on providing those. If you've talked to any providers in your districts, you've discovered that that's true. In addition, I want to make sure that people understand that I think we've been trying to address issues for folks that have been more isolated during the pandemic. I don't want to minimize how difficult kind of isolation is for all of us. It's certainly true that it's even more difficult being isolated if you're an adult or a child with mental health problems. And sometimes these services are the only things that, the only contact people have. And so I think they're really critical during this pandemic. And they're also, particularly for DLS services, not being slated to look at immediately as a rate review, but I think that needs to be done. So the amendment's been provided. Certainly Anna and Luke could speak to it. And also I worked on this with Mallory Shaughnessy from the Alliance. And so I hope she can join us to speak to some of that. There you
go. Senator, may I ask if I can share this with the department now, because it's only been shared with the committee?
Sure.
Can I just ask Senator Claxton if somebody could email me? I don't seem to have a copy of Representative Madigan's amendment. Can that be resent to my email address?
Anna, you sent that out, right?
I did, and I just resent it because I copied the committee on sending it to the department just now.
Okay, thank you.
But yes, I did, Representative Madigan. It just only went to the committee. Do you want us to screen share it and go through it at all? Yeah, okay. Are you screen sharing it or am I, Erin?
I can try again, but I failed last time. But let's see.
I don't mind either.
Okay.
Can you see that?
We will in a moment. Yes, yes, and it even moves. Look at that.
Okay, good. Sorry.
So, Luke can leap in if I go astray at all. But it's drafted slightly differently from the Maxby one. Representative Madigan asked us to draft it as closely as we could, but it couldn't be done exactly the same way because of the Appendix K in the 1915C is not something that exists for mental health. So, and Molly can leap in if I go wrong too. So during the summer, there were some short-term payments to some of these services, but they were paid on a per member per month basis rather than a percentage on the rates. So that's why this is drafted as it's a 6-month period as opposed to a 4-month period. It's for the fiscal year starting, the rest of the fiscal year starting in January until the end of the fiscal year. And the reason this language is written as being distributed to providers of these services in equal proportion is to try and get at the per member per month language. That just basically means that it would be the funding is provided, and Luke worked out what that amount would be to be roughly equivalent to the 25%. And then but it's drafted this way so that it goes out as an extra per member per month. We really didn't know whether this was something that required a state plan amendment or not. So we just put in that language about state plan amendments or permissions from CMS, and that if there was no matching funds approved or available, it would be general fund. We also didn't know if there was a, sorry for saying this, Representative Madigan, we didn't know if there was an upper payment limit problem. So this, the first section is section 17, the section, and it's all of the rates in section 17, section 28, which is the children's mental health. It's the same language, just with section 28, and that's because Luke needs to break it apart for the funding. And then the last section is some parts in section 65 that we were given the list for all of these from Mallory. So you'll have to ask her if you have more specific questions about the actual services, but you can see there that the services are home and community-based treatment for children, children's behavioral health day treatment, multi-system therapy for children, crisis services for adults and children, and mental health psychosocial clubhouse services for adults. So the first two were all of the rates within those sections, but section 65 covers a lot of different things. So other than that, the language is largely the same. And I think you can go down here and show so the fiscal, this is out of my wheelhouse. This is now into Luke's wheelhouse. So that's and that's how it's different from Laura's amendment.
And you'll see here that there are just 3 different appropriations, and that's just because we wanted to break up the different parts. So you see the first one is for section 17, the second one is for section 28, and the third one is for the section 65 services, for a total general fund impact of $10,750,000, with an additional $21.6 million from the federal expenditures fund, which would lead to a total impact of $32.3 million for the providers.
Related to this amendment, are there other things to be said, other questions to be asked? Yes, Representative Perry.
The question I ask, I guess I want to be clarified. This is for the supplemental budget and will only go for that period of time. Am I correct?
Through
You're
April.
correct. It's for the 6 months.
Yeah, the mental health is for the 6 months, and the Maxby one is for 4.
I think I don't understand. Because the Maxby one had some, it went back, had something to do with back pay.
It went back to January, but it was only to be for January, February, March, and April for the 25% increase. Okay. And then the retainer payment piece is only for 3 months, and that's just because that's the federal limit on the retainer payments is 3 months.
Thank you.
You're welcome.
Senator Baldacci.
Thank you, Mr. Chairman. I wanted to ask in terms of if have we gotten separate information like we did with the other bill in terms of how many people this would affect, and what are the rates going to be for these people after the supplemental budget? I don't know what the governor's provided. Do we have to vote on this today? Or can we take some time to consider this? I think it's a very important issue. I think Representative Madigan is correct in pointing out and making sure these are very important services. I just probably need some more information before I can make a final vote on this, but I'm obviously inclined to support it. I just need a little bit more information as to where it fits in the overall picture. So I just want to put those comments out there and thank Representative Madigan really for presenting this, because it's very important. Thank you.
So Senator Baldacci, I hear one question of the biennial budget and future rate, and those would be independent of these 2 amendments. And I don't know how specific we are in the biennial budget about rates, but
well, I know, but I think we're under the understanding that the amendment that you provided, that the governor's biennium budget is going to continue those type of rates. Correct?
If there's state matching money.
Right, right. I don't know if that's the same case. I don't know what the case is in the biennium budget for the rate increases that Representative Madigan has asked for. So I'm just looking for some more information to see what the, whether we're increasing rates for 20, for increasing rates for 6 months, but then we go back to normal, or what happens after the 6 months? I just want some more context. That's all I'm saying.
Yes, Representative Madigan, did you want to say something?
Yes, I just want to say that this may well be an issue we need to look at in the biennial budget coming up. But talking about the rates for mental health care is something that the department is doing, and I can't recall offhand what ones are being addressed right away. I do know that the rates for the daily living support services are not slated to be the first set of rate reviews.
Representative Connor, you had a question.
Yes, thank you, Mr. Chairman. I just want to make sure I have my head wrapped around this correctly, as I'm new to all of this. So I'm looking at some of these providers, and I want to make sure that we're not seeing double dipping here. What I mean by, I'm looking at one of these providers that provides, 16, 20, 21, and 65 services. So if that one provider is getting funds from Representative Madigan's amendment, as well as the initial amendment that we were looking at, these amendments are supposed to go to help providers with their employees, if I'm not mistaken. So if these employees are doing the exact same services, are we able to find that out? If one of these providers has, one employee who does the gamut, is it technically a double dip, if you will? I'm just trying to wrap my head around it.
Okay, it's a good question. And Representative Madigan would like to answer that or address that.
Thank you. Different agencies may well provide services that are addressed in either amendment, but the services tied to both in the First Amendment and the Second Amendment are tied to the diagnostic category, in particular a child or adult has. So for the section, for the First Amendment for Maxby, they would have to have a diagnosis of an intellectual or developmental disability, which is different than a mental health diagnosis as we understand it. It may well be that that an employee may provide. I mean, I can't think of anyone offhand I know that actually does provide services in both things, but the skill set is similar, that someone could do that, but they're not, someone isn't getting DLS services and services for IDDD, if that's what you're asking. I'm not quite sure.
Well, no, not necessarily. I just want to make sure that, like you had said, I get it that an employee can, could be providing for a child as well as IDD. But if this whole bill structure is to help compensate employees, it doesn't matter what the employee is doing. If they're wearing both hats, then are we required, or do they need the double dip, if that's the right term? I apologize for my terminology is incorrect, but that's kind of what I'm getting at, is if one employee is doing multiple things, why the need for two different amendments from two different pots of state money?
I think a lot of providers provide for either one population or the other.
And they're only going to be paid for the provision to an individual, not by a category. They're getting paid for compensation for the hours that they work X, but all this money goes through the organizations that provide the service, and they allocate the dollars. We're not driving the minimum wage for these folks. We're trying to keep, I think of it, envision it as a life-saving ring, as opposed to a boat rescue. We're trying to get them through and preserved through the end of this through June. And then whatever happens in the biennial is what happens in the biennial, but at least those folks will be there to provide services. Representative Meyer, you had your hand up, then I'm going to go to Luke and then Ms. Shaughnessy.
Yes, thank you. Thank you, Mr. Chair. So I just wanted to start by saying that this would be a recommendation to the Appropriations Committee, that we are a policy committee. And so I understand a lot of the questions here are sort of aimed at, how these things get paid for, but we leave that up to our colleagues in AFA, and we are a policy committee. So kind of looking at the big picture here, this is a short-term solution to an obvious long-term problem that this committee is well aware of. Representative Madigan spoke eloquently about the behavioral health workforce, and I agree with her 100%. I just want to, I just want to reiterate what we've heard time and time again from Max B with regard to the IDD community, and remind the committee that this is indeed short-term relief, much needed for a very vulnerable, medically fragile community that with a workforce that is exhausted and leaving their jobs, and they are very difficult jobs to fill again. That said, I would just like for everyone to just keep in mind that we are the Committee on Health and Human Services, and these are human beings who we represent, who have the kinds of needs that we really need to be laser focused on here, ensuring that these individuals and their families and the agencies that provide this critical service have what they need in the short term, and they need this.
So let's hear from a couple other people, and then I'll check back with you, Representative Connor, to see if we've adequately answered that question for you, because it's an important one. Representative Stover.
I just wanted to add that in response to Representative Connor's question, it's a fee-for-service arrangement. So if I'm receiving one service, that's that bill. If I happen to qualify for something else, it would be a separate fee-for-service. So I wouldn't be double dipping or getting multiple things at the same time. I might be eligible for multiple things, but it's unlikely or impossible that I would be getting them simultaneously, if that helps.
Senator Moore.
Thank you, Mr. Chair. I understand that these are some very, very critical positions, and we really do have a population that we've got to wrap our arms around and really take care of. I think what I'm concerned about is what other positions that are out there that also are in need of this life-saving ring. What are we opening up? I mean, I guess that's why I'm so hesitant about funding this a little bit here, and then we're going to have somebody else that needs it, and somebody else, and somebody else. So that's my concern. What else is out there that's also needing this similar type of funding?
That's a reasonable question, and I assume that there are advocates out there who can speak to that. Senator Perry, Representative Perry, sorry to demean you. You had a question?
Well, I did and I didn't. I did want to respond to Representative Connor's question. Having been a provider in the medical field, the money follows the patient. It does not follow the provider. What we're doing is allowing reimbursement to match the ability for the person providing the service to this client is able to get an added payment as a result. The other thing I was going to say, yes, we have a lot that we need to work with in terms of rates. I haven't had a chance to go through the response on the rate study, that was done. But I know that we are going to be seeing some increases. This is only to bail out, I don't know how to do this, to get people to survive through this end of this budget. And we are going to be looking at and working with a whole lot more once the biennial budget comes up.
So, Ms. Shaughnessy, thank you for joining us.
Hi, thank you. Nice to see you all again. Again, it's Mallory Shaughnessy with the Alliance for Addiction and Mental Health Services, Maine's safety net, really mostly Maine care and uninsured providers for mental health and substance use for children and adults across the state. And so there's several different questions that came up that I'd kind of like to touch on, but in part, this interim temporary rate increase is in part a COVID response still. There were some temporary rate increases last year during the pandemic to allow for retention of employees and sort of a hazard pay, if you will, to keep them working, but they were short-lived. They only lasted for a few months. And many of the providers have kept paying them because they can't keep their employees if they don't. And they are going in the hole. And this would be to help try to, finish off their fiscal year without huge gaps in bringing them up to cover that hazard pay many of them are already paying. We have things like in Portland with the referendum that went through of being mandated to pay $18 an hour. We had 2 children's residential services that actually had to just close with about 20 kids that were impacted because they could not financially pay their staff that increased rate at that level. So in part, it is really a COVID response. There is the rate, as Representative Perry mentioned, there is the rate evaluation that's happening right now, which is sort of evaluating how we do rates, which ones to look at first, and how we're going to do it moving forward. But it's not really a rate study per se. There are a couple of little rate studies happening. There's a number of bills in before you all this session that are addressing some of these on a longer term basis and making some, suggested changes to some of the services. But to try to sustain them over the long term. But right now, the situation we're in is, I can't remember who it was that said it, but keeping the services just happening as we see an increased need for these services for substance use and mental health during the pandemic, and just trying to keep these services flowing and open and staffed, which, we're running into more and more trouble with. There is the capacity currently to have an enhanced rate for some of the residential services if you have an active outbreak. And residential services aren't addressed in this. We had talked about the potential of maybe adding them into this, at least for children's residential, which doesn't have a cost-based settlement. But for them to actually be preventing COVID in their residential facility through the PPEs and through the quarantining people that may have been exposed and all of those things that are being done and costing money to try to prevent an outbreak, there is no additional funding for that. And one of the pieces I think somebody else mentioned about, I think it was actually Senator Moore, around other services beyond these ones and getting funding. You have to understand too that through the CARES Act and the money that came down to Maine, we received absolutely nothing through SAMHSA, the Federal Substance Abuse and Mental Health Services Administration. There was theoretically $2 million slated for Maine that never came, that we may be now getting, but Maine did not receive any dollars directly for our mental health and substance use through the CARES Act directly to these services. And some were able to avail themselves of some of the grants or some of the loan programs, but again, they didn't meet the full need. And they were short-lived. And we're still in the pandemic. We're still addressing, the issues, and our workers are still facing the hazards, and we're still having outbreaks and working hard to try not to. But in theory, this was like January through either through the end of the pandemic emergency time or through the end of the fiscal year, and we have some bills in to look at continuing it forward. So I've tried to hit on a couple of different pieces that came up. Let me know if I missed one that people have a question on.
Senator Moore, do you still have your hand up? Do you have a question? No. Okay. Representative Connor?
Yes, thank you, Mr. Chair. And I do appreciate my colleagues' filling me in. And like I said, it was out of ignorance on my part. I truly did not know. So I'm glad you guys all helped me and educate me on that. My final question that I have is probably more for Miss Cordons or Cortez. Humor me if you will. The state government continued to pay and reimburse for services throughout COVID. Is that a correct statement?
Yes.
Okay, so
Yes. So
when I think of, I did some precursory research on the PPP loans that I had asked you about during our last visit. And of the 16 that I saw, there was roughly $24 million from the federal government in PPP loans issued to those 16 agencies, those providers. In a normal circumstances, during COVID, Johnny's business, Acme business, whatever you want to call it, they received their funding to pay their employees from the market. When COVID hit and the market dried up, those revenues stopped coming in. Those companies needed to go to the federal government for PPP to pay their employees. However, these agencies continue to get payment from the state, reimbursement for services rendered, in addition to applying for and being granted over $24 million in federal money. So I'm just curious to know, I'm just curious to know why they needed additional funding if they were able to use the PPP funding in addition to being reimbursed by the state, and now there's still more needed. So I guess my question is more along the lines of, where did all of that money go, or what was it used for if more is still needed?
Sure. Well, maybe to use some of your framework, maybe the market is kind of fixed. So for Medicaid providers, so the services that we provide for Mainers who are eligible for medically necessary services, those rates are fixed. They're not negotiable, and that they have been, as you have heard from your colleagues and from our testimony, especially on residential service wage rate, now almost $1 below minimum wage. So for PPP loans, we're really vital to our providers. I did today send out information acknowledging that was, in addition to that 3-month 10% increase in the spring, that combined was what providers really relied on in the first several months of the pandemic to pay for the extraordinary cost of cleaning supplies, PPE, setting up air filtration systems, doing everything they could to keep operating, as well as then making up for that dollar that they're under, and then being able to pay hazard and incentive pay to keep folks that were rapidly leaving the workforce on the front lines. So that's the combination of things that they were able to pay for early on because of PPP loans.
Okay, thank you. That's all I have, Mr. Chairman.
Sure. Thank you, Representative Connor. So I want to, yes, Representative Mann, Mr. Mann.
Hi, thanks. I just wanted to weigh in a little bit. I'm not here to support or oppose either of the amendments, but I just wanted to provide a little bit of information that might be helpful for the committee to inform your recommendations and just for your own awareness as well. I think just off the top, it's helpful. Maine has done a great job, frankly, in since the beginning of the pandemic, and all the metrics compared to other states, we've been consistently in the top 3 or 4 in the total number of cases per capita, the total hospitalizations per capita, and the total deaths per capita. So we, on a relative basis, COVID has unquestionably been horrible, and on a relative basis, we have fared better than other states, thanks in large part to the people here and providers and everyone making sure that we can try to manage the best as we can here. I wasn't aware of the Second Amendment on behavioral health, but I just wanted to make sure that you all were aware that we did, and I think Luke or Anna mentioned this, we did provide behavioral health supplemental per member per month payments that went out in August. The payments went out in August, September, and October. believe it was close to $4.5 million. It was someplace between $4 to $5 million for those payments for certain services that spanned Section 17, 65, and 28. We also passed in the supplemental that passed last year in fiscal 20 that took effect on 7/1. There were rate increases for Section 65 that we actually accelerated early and put that into effect on April 1 instead of waiting for July 1. And we can talk about biennial budget initiatives. We'll be talking about that later this month. I know there aren't that much on rate increases, but we do have the comprehensive rate system evaluation that shows some rates are higher, some rates are lower, and we intend to prioritize that, and we'll have, I'm sure, in-depth conversations on that front. There are a series of supports that will further strengthen the mental health continuum here in the state, whether it's IOP, intensive outpatient services for main care, crisis center, or other. We can talk about that, like I said, during the biennial budget. I think in terms of state, in addition to the PMPM and the accelerated rates, the providers were eligible, all main care providers were eligible for the DECD grant program. We talked about that a bit last week. I think it is telling that we also mentioned last week that the IDD providers were not able to avail themselves of that because that program was need-based. They had to show a certain financial threshold of loss, and they did not demonstrate that, or they had sufficient federal resources that offset any losses for calendar year 20. Maine providers overall received over $500 million through the CARES Act. Most of that, the majority of that went to hospitals and nursing facilities, but all main care providers were eligible to apply for the certain programs that HHS and DC set up that reimbursed 2% of annual revenues. And that is separate and distinct from the Paycheck Protection Program, which provided $2.3 billion to Maine providers. That's not all healthcare. That was to all providers in the state. I don't have a breakout for healthcare providers in the state on that. But furthermore, any nonprofit in the state is also eligible for FEMA reimbursement, which is 75% of COVID-related costs that are pandemic related. And so I think, I guess I just provide that just for your full context and awareness. I think unquestionably the facilities, we can talk more about congregate care and other supports that have been put in place at a separate time if you're interested. But I think it is important to remember that a lot of the, I thought the DECD grant program was especially effective because it did prioritize providers that did have need, because COVID has impacted everyone, but it's impacted certain facilities far greater and in much more intense ways than other facilities, depending on where you are in the state, what services you provide, if it's a congregate care setting or otherwise. And certainly the utilization of services has been uneven during the pandemic as well. I think it's been hard, but not all services have been impacted equally.
Okay, so at this point, this is a ton of information. It's late in the game. I totally concede that. And we have to tell the folks at AFA by Friday what our priorities are. I want to reinforce what Representative Meyer said, that this is a policy committee. We're not committing anybody to spend this money. We're saying this is important to us or not when we get to that vote. And I just want to acknowledge that piece. And then I want to get a sense about whether we should let this sit overnight and let people catch up and think about it and then bring it up for a work session tomorrow afternoon, or whether you want to keep going for right now. And I would, anybody can weigh in. Yes, Senator Baldacci.
My preference would be just to do the votes tonight and get it done.
Okay. Anybody else got a sentiment that they want to share? I saw some head nodding from Senator Moore. Would you like some time to digest this, or do you think that would be helpful or not?
On my behalf, no, I know where I stand on it right now.
Okay.
I was thinking there was some others that expressed some concerns about really wanting to put their hands around, their head around the numbers and so forth. So I'm good either way, Senator.
Okay. Thank you, because you're also representing Representative Javner in her absence because she couldn't join us this afternoon. So you can put up both hands. All right. So is there anybody who else besides Senator Baldacci who would like to pursue this and potentially wrap it up this evening? Because it seems to me one of the other options is to combine these two into one, call it a single amendment, and then sort out what the priorities are for the committee, how many people are really comfortable with supporting IDD and behavioral health at the same time versus one group or the other. So I'm open to feedback about that. Let me okay, Representative Craven. Then
Thank you.
Representative Madigan.
I think that Anna talked about them being different and that it probably would be difficult to roll them into one. Is that right, Anna?
I think that's a decision that's up to you. They're all separate sections within an amendment. If you want to send it as one amendment, I guess that's your choice. I don't think it makes any difference to us, Representative Craven. Unless Luke tells me I'm wrong.
Yeah, well, I'm just a little confused, I guess, because that the IDD amendment was with the Appendix K and the mental health one was.
So what I hear Anna saying is that those are standalone paragraphs, basically, that can be combined in a single bill.
Okay.
Yeah, it's totally your choice.
Okay. Representative Madigan, you had a hand up.
Yeah, I like the idea of rolling them in together just because I've been pretty outspoken on the committee this year and in the past that I think there has often been a split on these very similar services that I feel, has pitted one group against the other. And I think that's done a disservice to the populations, to the providers, and actually to the members of these bodies, that I don't think that serves anyone. And I think what we're talking about is necessary services for vulnerable populations. So I would support us rolling it all together.
Representative Connor.
Yes, Mr. Chair. I was getting ready to make a motion to table this and have it combined and vote tomorrow.
Is there a second for that motion? Senator Baldacci, did you want to second that since that was your inclination?
No, I don't think that was my inclination. My inclination was to vote tonight.
Oh, that's right. The other way around.
Okay, thank you.
Well, for this, anybody want to second that?
I'll second it.
That was Representative Griffin. Okay. So I guess we go to Carrie to call the roll on the motion to table for reconsideration tomorrow afternoon after we get done some interested party work and statutory bodies. So if Carrie's there and can call the roll, I'd be
Sure
great.
thing. Representative Zager.
I'm sorry, Mr. Chair.
Motion on the floor is to table and then bring up for reconsideration tomorrow afternoon in another work session.
Yes.
Representative Lemlin.
Yes.
Representative Stover.
Yes.
Senator Baldacci.
Yes, since that is the desire of the amendment sponsors?
Representative Perry,
Yes.
Representative Griffin,
I saw a yes, I didn't hear yes.
You're
Representative
muted.
Griffin, you're still my yes.
Yes.
Thank
Rep-
you.
Representative Connor,
Yes.
Representative Craven,
Yes.
Representative Madigan,
Yes.
Representative Javner. Representative Javner is absent. Senator Moore,
Yes.
Representative Meyer,
Yes.
Senator Claxton.
Yes. So that's unanimous to table until a work session tomorrow. Do you have your hand up, Representative Madigan?
Yes, I would like for tomorrow, just because I think it's important as we think about this. I believe it was Mr. Mann referred to the CARES Act money. I wonder, can we see a breakout of how much of that money went to hospitals, nursing homes, mental health, substance use disorder, and IDD, DD community, so we would have a better idea on how that money got broken out and dispensed to them? Is that possible for us to get?
HHS has a lot of information on their website. Those payments, the Provider Relief Fund, which was 175 billion appropriated over a couple pieces of legislation, went directly from the federal government to providers, not through the state. So I don't have a good insight into that. However, there is a lot of data on the HHS website that can be mined. I know they have they just put up a new graphic on overall amounts, but it would take some manual machinations to break it apart, I believe.
Thank you.
Representative Craven?
Thank you, Mr. Chair. I would like to know also how much of the FEMA grants were paid out. It seems to me that I heard from providers that the application was so complicated, or and that a lot of the IDD providers didn't qualify to get reimbursed for their equipment. And I wondered if there was some way to know how much FEMA paid out.
I can inquire. I don't mean to not have an answer for two back-to-back questions, but those FEMA applications don't run through DHHS, so I would have to. I don't know if that information is public or not. I can look into that though.
Are there other questions we'd like to have answered to make tomorrow's conversation, which will be the last one about this, any easier or more thorough for folks?
Mr. Chairman?
Yes, sir. Senator Baldacci.
Thanks. I think Mr. Mann had referenced during some of his comments, economic recovery grants from DECD. And can he, between now and tomorrow, can you let us know? This is very speculative information that you're giving us. So I guess, can you give us better information tomorrow? If you're suggesting that these agencies got DECD economic recovery grants, I guess you should be able to pinpoint that and let us know what the specifics are in terms of total amounts. I think that would be helpful. Instead of speculating that they may have got grants or they may not have. I think we need to know from the official records if a lot of these agencies got grants and how widespread and how much money total. Thank you.
Senator, if I could just, I think that information is available with the information Anna provided the other day to the DAF's website. It says right here, economic recovery grants for small businesses, about halfway down that page. That might be a resource for you.
Just to clarify, sorry to cut you off at the end there, Aaron. The information on the website, off the top of my head, I believe Maine businesses got $240 million through that program. It covered 4,700 businesses and organizations. And I wasn't, the information that I said, to my knowledge, the IDD providers did not qualify for that because they were ineligible because they did not meet the financial loss threshold.
Okay, I mean, I don't know what the financial loss threshold, how that is calculated for a nonprofit versus a commercial entity, but
it was the same.
Okay, so none of these providers received any kind of economic recovery grants?
The DECD program, the first round was 50 open to businesses with 50 employees and smaller. There was another round open to 250 employees and smaller, irrespective of what industry you work in Maine. And then DHHS partnered with DECD to open up the Maine Healthcare Financial Relief Grant Program, which we made available to all hospitals and nursing facilities and providers over 250 employees. So all healthcare providers in Maine had an opportunity to apply for that if they chose to do so. Through that last round, I'm aware that the IDD providers did not qualify for that program.
Okay, I appreciate the information. Thank you.
They didn't make the 20% threshold. Is that right? The 20% loss?
The first litmus test was that you had to show a 20% reduction in your net position, basically revenue minus expenses from 2020 compared to 2019.
Okay.
And then also, if you met that, you also had to show that you didn't have financial funds that were provided from the federal government in excess of that.
Can I just make one more statement, Mr. Chairman? Because I think we're really, and maybe I'm the only one who thinks this, but I think we're kind of comparing apples to oranges when we're talking about these grants, because there's a difference between the entity having to show a loss versus what we're talking about here is that wages for workers who have been stagnant. And I understand, so basically these agencies were able to keep workers' wages stagnant, and they were able to not to lose their shirts. Okay, I'm not sure that just because they got a PPP or economic, that it really answers the questions that we need to focus on, which is these wages have been stagnant. We have a major labor shortage. These people care for the vulnerable population. Okay, these programs that we've talked about are one-time relief funds. What we're trying to do is provide a permanent rate. Well, I understand it's just in the supplemental budget, but we're trying to push up wages in these areas in order to attract labor, which is now incredibly, if anybody has a child or an adult with disabilities or or an older person who needs home health care, any of these services that we're talking about, there is an incredible shortage of skilled people. And so I think, to be honest with you, and I don't mean to, but I think the whole discussion about trying to figure out PPP money or economic recovery grants is frankly irrelevant to this discussion when we're talking about attacking, curbing, curing a labor shortage, because people can not lose their shirts by keeping everybody stagnant, but that doesn't solve the underlying problems. Thank you.
Thank you, Senator. Were there any other hands? Not seeing any, I would entertain a motion to adjourn until tomorrow.
So moved.
Thank you. All those in favor? And I do want to thank everybody. This is complicated content. There's a lot of new content. It's not the ideal way to do things. With the biennial budget, we'll have a much longer lead time and a chance to ask questions, but these amendments showed up late. So I apologize for that part, but it was driven by the fact, as Senator Baldacci's pointed out, that we have a labor and fulfillment and retention issue. So that's what the heart of it was. So thank you all for putting up with the vagaries of Zoom. And